So, good morning to all. I couldn't hear you. Good morning to all. That's good. Okay. Can anyone of you tell me why you have gathered here? Why you have gathered here? On palliative care module. Okay. Anyone knows what is palliative care then? What is palliative care? Any idea? What? Okay, it is a seriously ill patients nokunna. Okay. As we entered into this campus, especially to your college, I think so many things were displayed over there, right? I think you people must have made it. But then you should know now what is palliative care, because most of the things have been already told what is being done and what is going on. So what I felt was, then what is the point in me explaining to you palliative care when palliative care is here since years together? Okay, so then still, let us see what it is. So when we talk about palliative care, enhancing quality of life through compassionate care, we need to know also a little bit what it is. Okay. So the WHO definition of health, you all know, it says it is a complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That's a WHO definition, okay, about the health. Can anyone tell me what is the Florence Nightingale definition of nursing? I don't want about Virginia Henderson. I don't want, because Florence Nightingale is my favorite. So, any idea? She said nursing is an art and science. What is that? Nursing is an art and science. So usually I say nursing is only having a science now. No art is there. Art has gone. Okay, but when we talk about palliative care, there is still art in palliative care. Why, you know? Because whatever resources we are having, we use that resources for the patient when we reach out to their home setting. Because it is not affordable for them to buy all the things that a corporate hospital gives them. Okay, so there is an art in palliative care. So when Florence Nightingale said, nursing is an art and science. So that art is still there. Only thing is we have forgotten to take it into our time. So the curiosity of engine of achievement. If you see here, when we talk about palliative care, most of the time this happens. They ask this question. You just have a look. Who, what, when, how, where this keeps on triggering in their mind when they hear about palliative care, because everybody believes that palliative care is terminal care, which is not so. Palliative care is not a terminal care. So that is why when people come to palliative care, they ask a question. You know what question they ask? Am I going to die? That is why they have sent me to the palliative care? No. So you can, excuse me, lights and all. Backside, can you see this one? No, okay. So it is said, someday we all die, Snoopy. True, but on all the other days, we will not. If we are born, we are to die. We have to die one day. But the other days we are leaving. So when we leave, we need a good quality of life. So you get up in the morning, you do your prayers, you wash yourself, you have your breakfast. That's the quality of life. If you are not able to do that self-care, your quality of life goes down. Okay, so till we are alive, our quality of life should be the best. So the patients also, we need to give a good quality of life. Life isn't about waiting for the storm to pass. It is about learning to dance in the rain. See, in our life, storms comes up and down. In patient's life also, everything will come. But if we start grumbling on these things, our life will stop there. But we need to dance. That's what they say. We need to dance also in the rain. So we need to learn how to go ahead. I think you all must have heard in your childhood about an elephant. 5 blind persons were asked to just check out and say what they have seen. കേട്ടിട്ടുണ്ടോ കഥ? ആര് കേൾക്കാനല്ലേ? കേട്ടിട്ടുണ്ടല്ലേ? Same thing is like palliative care also. If you ask someone, nobody knows exactly what is palliative care. And especially if you go out of Kerala, it's very difficult to make them understand what is palliative care. Of course, in Kerala, people knows a bit of palliative care, but not outside Kerala. They all feel palliative care means it is terminal care. So, when we see what is palliative care, we say there should be a symptom relief, psychological support for the patients, social support, spiritual support, financial support, good quality of life. Let the patient be, even at the end of life, we need to give them a good quality of life. I'll come to that. Good end of life care we need to give to the patient, and peaceful death. Now when we talk about good quality of life, I will tell you, when I am in the deathbed, if you give me a little small piece of chocolate, I will die peacefully. Even if I have pain, I'm not bothered about pain because I love chocolate. Followed? So if a patient says, I still remember my mother, when she was in the bed, she was there for 2 days only as a bedridden, not even bedridden I will say. With support I was able to take her. She said she wanted to take biryani. Okay. Small teaspoon, 2 teaspoons of biryani she had taken. Okay, because she loves biryani, she loves sweets. And whoever came to visit her, she told them, I have taken biryani. So they were looking at me like this and they asked, Stella, Mummy has eaten biryani? I said, just 2 spoons. But today if you ask me, when I see that biryani, I feel so happy. Why, Because my mom's wish was that she wanted to have a biryani before she dies. So that is quality of life. So don't think quality of life is only pain relief, nausea, vomiting relief and all these things. No, only physical. It has a lot of psychological, social, spiritual, financial, everything comes in that quality of life. So when a patient told me, family, they all are from abroad, they had come down, they said, ഉമ്മ ഒന്നും കഴിക്കുന്നില്ല. ഐ ഹോപ്പ് ഓൾ വിൽ ഫോളോ മലയാളം ഓൾസോ ഹിയർ, റൈറ്റ്? ഓക്കെ. സോ പറഞ്ഞു ഉമ്മ ഒന്നും കഴിക്കുന്നില്ല. ഷീ 75 years old. ഓക്കെ. സോ ഐ ജസ്റ്റ് ഇങ്ങനെ ബെൻഡ് ചെയ്തിട്ട് ഞാൻ ചോദിച്ചു, അമ്മ എന്താ ഒന്നും കഴിക്കാത്ത? ഷീ വാസ് ജസ്റ്റ് കീപ്പിംഗ് ക്വയറ്റ്. ദെൻ ഐ ആസ്ക്ഡ് ദ സെക്കൻഡ് ക്വസ്റ്റ്യൻ വാസ്, ഇഷ്ടപ്പെട്ടത് എന്തെങ്കിലും തരാത്തത് കൊണ്ടാണ്? ദെൻ ഷീ സെഡ് യെസ്. ദെൻ ഐ ആസ്ക്ഡ് വാട്ട്? ഷീ സെഡ് കപ്പ. When she said just kappa, immediately son told, Umma diabetic aanu. And you know what she said? Oru kashnam kappa thinnittu njan marichalum I'm happy. That is quality of life. I hope you got it what it is. Okay. So globally, if we see, only about 14% of the people receive palliative care. I don't know this side, you people will be able to see. You can see 86% of the people who need palliative care do not receive it. 83% of the world's population lack of access to pain relief. And of course, 98% of the children need palliative care. So you just see, we say, in India, if you take, it was 2%, now it is 4% of palliative care. And after that 4%, if you say, 2% is in Kerala. So you know, 2% is only in other parts of the states. So what palliative care is there? Many of the patients die because of pain. Recently, one youngster, I think somewhere about he was 25 or 27 years old, he committed suicide. In his suicide note, he wrote, I am not able to tolerate my pain, so that I am leaving this world. Okay. So the evolution of the concept was palliative care. That is in 1990, it said total care of the patient and their family. If there is no more response, we took curative treatment. But by the time 2002, you can see what it is written there. Improves the quality of life of the patient and their families. 24/7, patients are taken by their families. So, it's don't keep the patient family separate. When you take care of a patient, see that next to them, one family member is there. You need to take care of a family member also. I just want to ask you, how many of you ask your patient's family whether you had a breakfast, whether you had a tea or a lunch? Mostly none of you. I tell you, from today onwards, practice that. When you see a patient and a family next to them, maybe a mother, father, son, anyone, just turn to them and ask them, did you have tea? Did you have lunch? You see what is going to happen. I still remember when I was in Indore, I had taken a session for students. I just told them. The next day, one of the students, she came and told me, when I entered a room, son was admitted. I asked him whether he had the lunch. Then I asked the mother, "Aapne khana khaya?" She said, that lady just came and hugged her. And she said, first time someone asked me that whether I had a lunch. Many times this happens, the patient's family won't have lunch. They must have not slept properly. Just take care of them also. They feel very good. And I tell you, anytime you pass from that side, now they will tell, that sister, she's a very nice one. She's a very good one. That is also again a quality of life. Prevention and relief of the suffering by means of early identification. Then comes treatment of pain and other problems, physical, psychological, social, and spiritual. So we need to do a good assessment to find out what is their problems. I'll be coming to that. So quality of life is what a person says it is. It's not that I say the pain is relieved, the patient's quality of life is very good. No. Patient has to say that this is what I want and this is what is being done. My quality of life is good. Before that, I have seen my daughter's marriage. My quality of life is good. Quality of life relates to an individual's subjective satisfaction with life and is influenced by all the dimensions of personhood. See, physical, psychological, social, and spiritual. So that is important. So wherever the patient is located, you can give palliative care. It can be in your ICU, it can be in your medical ward, surgical ward, anywhere. It doesn't mean that you have to give palliative care only to a patient who is admitted in palliative care. No. Remember one thing, any patient, whether acute or chronic, admitted in your hospital needs a palliative care. Apart from physical, every patient family has a psychosocial, spiritual, financial problems. Address that. If you address that, the patients will be better off. Their physical problems will reduce. So palliative care, it is just a word, palliate. Pallium means cloak or cover. I know you all are having tensions and stress, right? Right or wrong? Do you have? No. Good, eh? I should appreciate your tutors for that, if they're not giving you any stress and tension. We all have our own stress, tension in our life. Okay? And if one of your classmates, see, if you are sitting alone in your room and you are having a headache, your friend is coming and asking you, what happened? And she's trying to console you. How do you feel about it? You will feel good or bad? You'll feel good. Right, okay. In the same way, any patient, any family in the hospital, when we approach them, we try to find out, other than physical, what is their problem. They feel very happy about it. Because I'm sharing my problem to you. So what happened? My stress, my tension reduces. So that is what the patient and the family wants. So there is nothing more I can do. In palliative care, there is always something I can do. I'll just put one. I'll come to that. Not just for life-threatening situation. So previously we were telling it is only just life-threatening illness. But it's not like that. You just have a look. Elevation of the suffering is needed for all who have a curable as well as those with the incurable. So any patient anywhere, you can give palliative care. So what is new about palliative care? Palliative medicine, it's an old medicine, the revival of the whole person approach. Previously in my olden times, my time I should say, okay, because I am 62 plus now. So in my time I should say, when I was a child, they don't see only as a disease, the person. Nowadays what we see, we will say, bed number 6, see a breast. Bed number 4, stroke. Okay. But instead of that, we are a living person. We need to address the patient by their name. Please don't address the patient by their bed number and their diagnosis. Remember this one thing. Just put yourself in that place. Someone tells you this is CA breast. How do you like it? You have a name? You are a human being? Alive? So don't address the patients by bed number and diagnosis. Here, the first main thing is the palliative care syllabus was included in the nursing. I still remember 2012-15 when Rajgopalan sir called me and some of us, we were there. We actually did the curriculum, we made the module, everything was placed. Since that time, you won't believe, 2017, nothing happened. So you know what our INC is sitting and doing. Okay, every time we go and ask, they will tell, palliative care, that was the answer. Okay, thankfully when I met one of a person from the government of India, one of a very senior person who was an additional director, he asked me I don't know why he asked me, can I do anything for you, Stella? I said, sir, one thing we have to do. Dr. Rajagopalan has submitted the proposal of including the curriculum to nursing and plus the medical also, of course. But nothing has gone ahead now. So he told me, just send me a proposal again. With the proposal what sir has kept, send it, I will do it. They did it. See, it has to go, it never went like this, it went like this. So, advances were made in pharmacology. What? Many medications which we use in palliative care is psychiatric medicines also. but it's for neuropathic pain. Been done, and of course, radiotherapy. So this is a concept I would like to say. You can see this. Previous concept was that old concept. Once the patient is not having any curative, they will be just pushed to palliative care. But now you see, the better concept was, right from the diagnosis, you can see here, right from the diagnosis, we can give palliative care. Why, curative part they are taking care of. But what are the symptoms of the patient? What about their psychological, social, spiritual problems? So right from the diagnosis, we can support the patient. Why, as the days goes, you see, this is narrowing. But you see the palliative care? As it goes, it is broadening. So by the end, the patient is fully with us. And of course, we can give the patient a very good end-of-life care. The patient can have a dignified death. And of course, last is bereavement. We see that if the patient is, after the patient dies also, visit the family member, find out how they cope up with the loss. What is happening with them. At times even we can see that if the patient has died at home, they will tell how the patient died, who are there at. Because we all love. Who loves to die in hospital? No one, eh? You all want to die at home only? No or yes? My God. No answer at all. I think they want to die in the hospital, ICU. No. So, even patients, when they say that we want to die at home, why if we, as they said, surrounded by beloved ones, right? Okay. So, that is what happens over here. So, palliative, I don't know whether you will be able to read this. This is what is told about the palliative care. Provides relief from pain and other symptoms. Affirms life and regards dying as a normal process. We don't try to hold the life of the patient. When the patient has to go, let it go. We don't give them medication. We don't put them in ventilators so the patient will drag and drag and drag and die. No. Leave them when they want to go because it's a normal process. Integrates the psychological, social and spiritual problems, whatever we do, address that. Also, we give support to the family and very important impact, this one is educating the family member how to take care of the patient. I'll just tell you one thing, very simple thing what you people can do. Before the patient gets discharged from the hospital, just teach them how to make an occupied bed. They all want to know how to make it occupied. They don't know. They struggle at home, pulling and pushing the patient. We say pressure ulcer, no? Friction. That's what's happening at home. Just teach them, as you teach them how to give a NGT feeding, right? Teach them how to make an occupied bed also. Without no one's help, they will do it at home. They'll be thankful to you. So, palliative care teaches the patient, family member how to take care of a patient, how to give a feed, how to dress a wound, whether it is a normal wound, whether it is a malignant wound. How to take care of a colostomy, how to take care of how to apply a lymphedema care. This everything palliative care teaches the family. That is empowering the family member. And again, why are we asking about palliative care? Our aging population is increasing. By 2050, I think double, more than 30% of the youngsters more will be the elderly people. If 5 youngsters are there, almost 20 elderly people will be there. Who is going to take care of them? Because while geriatric care is very important because they have a lot of problems. And of course the death, I asked you, I don't want to go into that. So who needs palliative care? You can have a look on this. Palliative care is only not for a patient who is having cancer, but for matter, any patient can come into palliative care. So I was just asking, you can just have a look at this. 52 years history of hypertension, diabetics since past 5 years, not on proper medication. He had a stroke. He was taken care. He had a problem with bowel, bladder incontinence, finding difficult to swallowing and speech. Renal function showing creatinine level raised. His wife is a caregiver, 4 children and old grandparents. What are the care to be provided in the initial stage and followed by discharge of the patient? And doctor says his condition can be improved with proper management. What are the support needed for this patient? Usually what happens, no? They say, ഇനിയിപ്പോൾ ഒന്നും ചെയ്യാനില്ല വീട്ടിലേക്ക് കൊണ്ടുപോയിക്കോളാൻ പറയും. അങ്ങനെയാണ് സാധാരണ പറയുന്നത്. But just think, a patient who is discharged from the hospital with a NGT tube, with a urinary catheter, otherwise nothing, patient is having a left-sided hemiplegia. Nothing to be done for that patient? Nothing? Or still something we can do for the patient? What do you say? A patient എന്തെങ്കിലും ചെയ്യാനുണ്ടോ ഇല്ലയോ? ഹോസ്പിറ്റലിൽ നിന്ന് പറയുന്നത് എന്താ? നത്തിങ് ഈസ് ദർ, കൊണ്ടുപോയിക്കോളാനാണ് പറയുന്നല്ലേ? ചെയ്യാനുണ്ട് അല്ലേ? സോ സി, നമ്മൾ പറയുന്ന പോലെയല്ല what we see. Once a patient is taken to home, patient has a lot of things to be done for that patient. NGT care, catheter care, sponge bath, otherwise bath we have to give to the patient. We have to take care of the patient, head to foot we need to take care. Okay, so what we say is very wrong. So you can see this patient, once the patient is discharged, his care starts from there till his death. So we need to take care of that patient, and that is very important for him. So this patient's care doesn't stop when he is discharged from the hospital. Actually the care starts from there. So these are the domains of palliative care, almost most. So some things which are the structure and process of the care, I spoke to you, physical, psychological, social and spiritual. That is there. Culture is also very important. Culturally applicable things has to be applied. Don't impose your culture onto someone else. I had, that was my first time in my life, one patient, after his death, we give last office, right? We clean everything, we put this one, that one, everything. But you know, many times this happens, many of the people, they don't like putting cotton inside the nose and tying this thing, most of the time. But we never ask. So we'll continue. I'm going to stop. It's for inauguration time, okay?
As the Achan has arrived, we will be shortly starting the inauguration. Now, we request the dignitaries to take their seats on the dais. I request the dignitaries to please take their seats. Starting our official inauguration ceremony by invoking the blessing of the Almighty for the prayer song we invite the college choir. Let's all raise.
കാണായ ലോകങ്ങൾ കാക്കുന്ന ദേവാ, കാരുണ്യ സിന്ധു നമിക്കുന്നു ഞങ്ങൾ. കരളിൻ്റെ പൂക്കൾ നിൻ പാദതാരിൽ കാണിക്ക വച്ചു നമിക്കുന്നു ഞങ്ങൾ. കാണിക്ക വച്ചു നമിക്കുന്നു ഞങ്ങൾ. വിറയാർന്ന കൈകൾ ചലിക്കുന്ന നേരം, നീറുന്ന കരളിൻ്റെ കൈക്കുമ്പിളിൽ നീ ചൊരിയുക നാദാനി സ്നേഹധാര. നേരിൻ്റെ പാത തുറക്കണേ ദേവാ, നേരിൻ്റെ പാത തുറക്കണേ ദേവാ. കാണായ ലോകങ്ങൾ കാക്കുന്ന ദേവാ, കാരുണ്യ സിന്ധു നമിക്കുന്നു ഞങ്ങൾ.
Thank you all. Kindly take your seats. It is our privilege to invite a person who leads us with a rare blend of gentleness and strength. Under her nurturing guidance, Pushpagiri College of Nursing continues to grow as a center of compassion, knowledge, and excellence. May I warmly invite our beloved principal, Professor Vinitha Jacob, to deliver the welcome address.
A very warm good morning to one and all, distinguished guests and dear participants. I'm very pleased to see you all here this morning to explore and discuss the topic of palliative care. Palliative care is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Each year, an estimated 56.8 million people are in need of palliative care, most of whom live in low and middle-income countries. National health systems are responsible for including palliative care in the continuum of care for people with chronic and life-threatening conditions, linking it to prevention, early detection, and treatment programs. Palliative care uses a team approach to support patients and their caregivers. Being the part of multidisciplinary teams, the nursing workforce should be trained in palliative care skills, especially those who work with patients with a serious illness, as they play a vital role in delivering personalized end-of-life treatment, care, and comfort to patients, as well as valuable emotional support to their families at the most challenging times. As nurses, we will equip ourselves to meet this challenging role through education, practice, and research. At this outset, let me start with the responsibility entrusted to me, that is to welcome the guests and delegates. I'm truly honored to welcome you all to this workshop. Visionary leadership will inspire a team to overcome challenges and will set the standard for the team's attitude and success. With these words, I extend a courteous welcome to our dear CEO, Dr. Father Biju Varghese, to this occasion. Dear Father, you are with us as a catalyst in improving and inspiring us for the success of all our activities. It's our privilege to have you here to inaugurate this workshop. Leadership is the art of giving people a platform for spreading ideas that work. I'm extremely happy to welcome The president of the meeting, respected director, Reverend Father Matthew Puthenpurel, who is the inspiration for our all ventures. Father is always with us, not as a leader, but one among us, and extends all the support for the conduct of any program of our college. A very warm welcome, Father. Forget about the fast lane. If you really want to fly, just harness your power to your passion. I'm honored to extend a very warm welcome to our eminent resource persons with a passion for palliative care. Lieutenant Mrs. Alice Stella Virginia, Dr. P.T. Thambi, and Lieutenant Colonel Lovely Anthony. They are with us here now. Lieutenant Mrs. Alice Stella Virginia, retired from Army, worked in government MCH Calicut, a very dynamic and a highly accomplished individual with a high profile in the field of palliative care. Resource person for development of a training manual for training doctors, nurses, and community health workers, compiled and published a modified manual for BCCPN. She won a certificate of appreciation as a nursing in charge of Buka Hospital, Sultanate of Oman, Best Nurse Award from IMA Kozhikode, International Award in Palliative Care, Award for Excellence and Leadership in Palliative Nursing by Cancer Aid Society, Lucknow. She was recognized as a national leader from India in 2020, the International Year of Nurse and Midwives, and was launched on World Health Day. She has in her credit the End-of-Life Nursing Education Consortium Project, City of Hope, and American Association of Colleges of Nursing presented ELNNC Award for Excellence in 2021 and ELNAC Award in 2023 for group work. She has also contributed chapters for many books in palliative care for doctors, nurses, and volunteers, and resource person for many workshops and conferences. Your words of wisdom and encouragement will undoubtedly motivate our audience. Hearty welcome, Madam. Lieutenant Colonel Lovely Anthony, after serving Indian Armed Forces for 24 years, Madam obtained post-graduation from RGHS and MPhil from Manipal University. Underwent core training from End-of-Life Nursing Education Consortium, India in 2021, and foundation course in palliative nursing from Palliative India, Trivandrum 2022. Obtained Master Fellowship in Palliative Care from Institute of Palliative Medicine, Kozhikode in November 2023. Served as expert in developing curriculum and content for BVOC in patient care management, including geriatric and palliative care for Tata Institute of Social Sciences in collaboration with Palliative India 2022-2023. Served as member of drafting team for palliative care module, BSc Nursing Semester 4th of Indian Nursing Council 2022, undergone external quality assessor training for public health facilities. Now, Madam is working as professor and head of the department, Community Health Nursing, National College of Nursing. Madam is a national mentor in the Community Health Officer Mentoring Project of National Health System Resource Center, Government of India in collaboration with the Christian Medical College, Vellore and BMGF. External Quality Assessor of Public Health Facilities in NHSRC, Government of India, Reviewer of Indian Journal of Palliative Care, and Resource Person for IAPC, Palliative India, ELNAC India, and DNIP for Palliative Nursing Care. Madam has several publications, national and international journals, and we are very much honored to have such an eminent speaker of the day. A very hearty welcome, Madam. We have with us eminent speaker, Dr. P.T. Thambi. We know the heart and soul of Palliative Care Department of Pushpagiri Medical College Hospital, and a very eminent personality in the field of palliative care, providing care for so many people in the field and in the community. So sir's work is very tremendous, and we have a very wonderful person, Dr. P.T. Thambi here. Very warm welcome, sir. A very warm welcome to Sister Mary Jyoti, OSS Vice Principal, Administration, for all the support extended. Warm welcome to our CNO, Suvarna S. Panikar, Madam. A very warm welcome to Mrs. Sylvie Matthew, HOD, Medical Surgical Nursing, and the Organizing Secretary of this workshop, Congratulations, Mrs. Sylvie and team for organizing this workshop. Since a few months, you are behind this to plan and make this event a reality. A very warm welcome. Warm welcome to HODs and faculties of our college and the working committee of this workshop, faculties of this college. Last but not the least, I extend a very warm welcome to all our respected delegates from various institutions. Dear delegates, you are the beneficiaries. I am sure you are going to learn a lot in the next few hours. Enjoy your time at Pushpagiri. Have a great day.
Thank you, ma'am, for your warm words. We welcome you too to this occasion.
Now, it's an honor to invite a visionary leader who combines spiritual wisdom and administrative excellence. Achan leads Pushpagiri with foresight, dedication, and firm commitment. We are truly blessed to have his inspiring presence with us today. With great respect, I invite Reverend Father Biju Verghese, CEO of Pushpagiri Medical College Hospital, to deliver the inaugural address, which will be followed by lamp lighting.
Good morning, all. Respected Father Matthew Puthendurai, Director, Pushpagiri College of Nursing. Respected Ms. Sajida Thomas. Respected Ms. Anne Jomi. Lieutenant Ms. Alice Stella Verghese, Dr. P.T. Thambi, Lieutenant Colonel Lovely Anthony. Respected Principal Professor Vinida, Vice Principals, Delegates, my dear faculty members, and dearest students. First of all, I would like to appreciate Pushpagiri College of Nursing for conducting such a wonderful international seminar on senile living. Actually, it is a good initiative because those people who are sitting on the dais, actually they are a little bit worrying of having this introduced into our society because we people are getting little bit aged and you people are looking on us because you think that you will survive, but you will not survive because we are living in a stage where at least there are some people to look after us. But when you are getting into age, there will be nobody. So Pushpagiri College of Nursing has this in its foresight, and they are arranging such a wonderful seminar on palliative care. I would like to share one of my experiences. When I was a young priest in 2005, I used to in charge of our senior priests who are retired. They are living at Pallimala near Kuttur. Some of 10 priests are living there, and they were very much distressed and worried. And we used to provide everything, sumptuous food and a good chapel to pray and a good place for gathering. But they are not satisfied. One of our young priests, you might be knowing him, his name is Father Rabi. He became the director of the center, and he did a wonderful thing. He bought smartphones for all the priests, all the elderly priests, and he installed WhatsApp, Facebook, Instagram. And all those priests were a little bit worried and stressed at the early stages. They could not use this. At the midnight, one of the priests knocked at the door of Father Rabi and asked him, "Father, I cannot record voice and send that on WhatsApp." The things changed dramatically, and I can tell without any fantasy that our elderly priests are the ones who use the social media very fruitfully and usefully, and they are very much satisfied now. I mention this only because we did not give anything extra. With their money, they have bought phones. With their initiative, they could find time to use that, and they started using that. So, what did make them happy? Because they got engaged. Few days back in Malayalam Manorama, I don't think any one of you read newspaper. Anyone has read newspaper today? News Daily today? Students? Well done. Thank you, Principal. Appreciate you. Because I'm sure that you might not have time to read newspaper, but you should read newspaper. At least you should know who is the Chief Minister of Kerala today. In its business page, there is something called a boom. And the final sentences read like that, Oduvilan. In it is being told that, written that, there is a kind of business that is getting boomed, that is companionship. In Mumbai, it started. You will get people on an hourly basis to spend time with your elderly people. They will go to your houses, they will spend time with your elderly people, and also they will make them engaged, and they will make them happy, and they will charge on an hourly basis also. Dealing with the senile people is a lucrative business today. But for Pushpagiri, this palliative care is a loss-making business. In the presence of Thambi, Dr. Thambi, I can declare that. But Pushpagiri believes in humanitarian concern, and we treat people to have a better life in their last stages. I don't agree with one of the statements you have provided here. For embracing the end with dignity, I don't think, you don't make people to end their life with dignity. You make them live with dignity and glory. No one's life is becoming to an end, but the life continues because we believe in the life to be continued. I would like to appreciate the initiative which has been taken by the Pushpagiri College of Nursing for preparing the young generation with a foresight for the care of the elderly people. If you look around Tiruvalla, you may see a lot of institutions for palliative care. I think Pushpagiri Palliative Care is one of the premier ones in Kerala. Dr. Thambi is heading that. We are so proud to have this in Central Travancore. Don't do this for making money, but do this with an altruistic attitude and altruistic mind. Allow people to have a better life. Allow people to have a dignified, glorified death. Don't make them believe that their death is an end of their life, but admire them to take the last breath with confidence and faith in God. With these words, I would like to declare this international seminar is being inaugurated in the name of God. God bless all. Thank all the delegates and participants for coming to Pushpagiri and spending time with this venture. God bless all. Thank you.
Thank you, Acha. I request all the dignitaries to come forward and light the ceremonial lamp.
I request Mrs. Suvarna S. Panikkar to also join the lamp lighting.
Thank you all. Kindly be seated.
We are indeed privileged to have with us Reverend Father Matthew Puthenparil, the esteemed director of Pushpagiri College of Nursing, a meticulous leader and a guiding light. Father has always inspired us with his wisdom, discipline, and commitment to excellence. May I humbly invite Reverend Father Matthew Puthenparil to deliver the presidential address of this gathering.
Respected CEOcha, esteemed dignitaries, honorees, respected students, and my dear guests for this seminar. Good morning to one and all. It gives me immense joy and honor to welcome you all to this important seminar on palliative care. Today, we gather not just as professionals, but also as compassionate human beings who share a commitment to alleviating pain, suffering, and distress in those facing life and limiting illnesses. Palliative care is not merely about treating symptoms, but it's about restoring dignity, offering comfort, and ensuring quality of life. In a world that we often prioritizes cure, we must remember that care goes beyond cure. So that's what I understand of more of palliative care. Care goes beyond cure. When cure is no longer possible, compassionate care becomes the most powerful form of healing. As healthcare providers, caregivers, and policymakers, we must work together to build a system where every patient receives a holistic support in all areas like physical, emotional, social, and spiritual. Equally, the patient families also need our guidance and empathy. As they walk with their loved ones through the most difficult phases of life, I also take this opportunity to appreciate the dedicated palliative care teams, especially our dear Mariamma Chechi and our most beloved Tambisa, who run this palliative care palliative society in our Pushpagiri Medical College. They have become beacons of compassion in a world of Tiruvalla, or the whole world. I would like to thank all who make this event more beautiful, especially the eminent speakers who have come today among us. I would like to thank them for their wonderful effort who have made them to come here. So it's my joy to welcome you all and make this event fruitful and make this seminar be a light to all of our life. Thank you, one and all.
Thank you, Father.
Now, I invite Mrs. Sajida Thomas, Assistant Professor, Department of Medical Surgical Nursing, for the vote of thanks.
Good morning, everyone. I, Sajida Thomas, Faculty of Medical Surgical Department, feel very privileged to be able to present here on this auspicious occasion and be asked to deliver a vote of thanks on behalf of Medical Surgical Department, Pushpagiri College of Nursing. As we all know, saying thank you is a respectful way to show appreciation towards a person. But these words would be less about Reverend Father Dr. Biju Varghese, who is giving constant support and interest in our all activities. He makes us to think each one to feel this institution as their own. Thank you, Father, for your presence and blessings for this occasion. I feel very happy to thank our respected director, Father Matthew Puthanpure Election, who gives his full efforts to upgrade our college into higher level. Thank you, Father, for your presence, support, and care. I truly enthusiastic to extend our thanks to our dear Principal Ma'am, Vinitha Ma'am, because of whom this workshop was possible. She helped us to organize and connect with the eminent speakers. Thank you, Ma'am, for your presence, timely corrections, and valuable suggestions. I feel very proud to thank our eminent speakers, Lieutenant Mrs. Alice Stella Virginia and Mrs. Lovely Ma'am and Dr. Tambi Sir for your presence on this occasion. I feel very influenced and proud to thankful to our Tambi Sir, and we are influenced with his politeness and interest towards us. Tambi Sir, a special thanks to sir. Next, I thank our Suvarna Ma'am, who is our Chief Nursing Officer of Pushpagiri College, for her presence. And also, I thank our online speakers, Mrs. Anu Saviotelli, Mrs. Ann Jomi, for their participation. They are not here. Even though their absence, I feel thank. Next, a special thanks to all faculties, non-teaching staffs. Thank you, each one of you, for your technical support, assistance, and timely influence. Thank you. It is the great time to extend my sincere gratitude to all delegates from various hospitals, colleges, and also particularly my dear students. Thanks for your participation and interest. Thanks to everyone. Have a nice day.
Thank you, ma'am.
Here we have come to the end of the inaugural ceremony. So I would like to invite Alice Stella Virginia to continue the session. We will be shortly presenting our case presentations. Participants should be ready.
Our students have got a rich experience in palliative care setting. In order to share their case study presentation, let's invite Ms. Aksa Sara to present their patient.
very respected dignitaries, faculties, and all my dear friends. A very warm good morning to one and all present here. Myself, Aksa, and I'm here to share my case presentation on metastatic endometrial carcinoma. As we all know, metastatic endometrial carcinoma refers to the type of cancer that arises from the lining of the uterus and that spreads beyond to distant organs. It is the most common type of cancer which we can see in the postmenopausal women between the ages 55 and 65 years of age. The incident rate of endometrial carcinoma rose from 8.1% to 9.6% worldwide. As a part of my clinical posting, I have got patient Mrs. X, 63 years old female, conscious and oriented, ambulatory female patient, came with the complaints of decreased appetite, episodes of vomiting and pain in the oral cavity since 2 weeks, and abdominal pain and pus in the urine since 2 days. She had consulted in the oncology department, and after further investigations such as CT and MRI, it was diagnosed as metastatic endometrial carcinoma. The lab investigation shows the patient was anemic with the HB level of 10.4 gram percentage and hyponatremic with the sodium value of 128 mg by dl, and the DCP values and ESR values are elevated. The special investigations include CT abdomen and MRI pelvis. In MRI pelvis, it is shown that presence of metastatic lesions within the endometrial cavity, and also in CECT abdomen, hypoenhancing lesions are seen in the endometrial cavity, and also retroperitoneal and pelvic metastatic lymphadenopathy present. Moving to the progression of the disease, initially the patient was diagnosed with CA endometrium in Alpura Medical College Hospital, and then she started chemotherapy with a combination of carboplatin and paclitaxel medications. She has undergone 6 cycles of chemotherapy, and after that she stopped it. Then she had postmenopausal bleeding till 2023, and so she underwent total abdominal hysterectomy plus BSO plus omentectomy, cytoreduction and tumor deposit excision. Now the patient was presented with the systemic complaints, and after investigation it was diagnosed as that carcinoma of endometrium has metastasized to the pelvic region. Next, the treatment modalities. It includes, initially the patient has done chemotherapy and then undergone surgical interventions, and now she was on the targeted therapy with TAP panzopanib 400 mg. Moving to the physical examination and focused assessment. The physical examination, the patient seems to be very tired and unhealthy with the unsteady gait and alopecia present and loss of muscle mass in the extremities. At the time of admission, the vital signs of the patients were stable, and also IV cannula of 22 gauge present on the right superficial vein. So moving to the focused assessment, the obstetric data includes age of menarche, she occurred at the age of 18, age of menopause at the age of 40, and hormonal therapy nil, and medical history of type 2 diabetes mellitus present. Moving to the outcome of the case, my patient, during 5 days of care, my patient maintained stable vitals, and the IO chart remains positive balance, and the pain was partially relieved, and episodes of vomiting decreased. Next, going to the nursing diagnosis. First is the acute pain related to tumor invasion as evidenced by pain scale score 7 by 10. Second is impaired nutritional status less than the body requirement related to loss of appetite as evidenced by less food intake. And third is a generalized weakness related to effect of therapy as evidenced by confinement to bed. So this is all about my case presentation. So as I am concluding my case presentation, so far I have presented my case on metastatic endometrial carcinoma. From this case, the thing that we can take away from this case is not only the clinical knowledge, but also the importance of holistic and compassionate care that we can give to a patient to improve and enhance the quality of well-being of that patient. So I thank all dear faculties for giving me such an opportunity to present my case. Thank you all.
Thank you, Aksa. That was a great presentation. Now, we'll be having an enlightening session on global access to palliative care, transcultural practice and policies. This session will be led by distinguished speaker Mrs. Ann Jomi, MSN, Senior Pain Nurse, Jaber, Al Ahmad Hospital, Kuwait. Let's welcome her with a round of applause.
I am Ann Jomi John. I'm working as a pain nurse in Jabir Al Ahmad Hospital, Kuwait, under Ministry of Health. So I'm here to explain you the global access to transcultural nursing and its practices and policies. Before beginning to transcultural nursing, we should know what is palliative care and what is the importance of transcultural nursing in palliative care. So, palliative care, it is not the regular care. We are giving a specialized medical approach that provides relief from the symptoms and stress of a serious illness to improve the quality of life for both patients and their families. It focuses on a person's mind, body, by spirit, by addressing physical pain, anxiety, depression, and spiritual needs, which provided by a interdisciplinary team. Every hospitals or every country will be having a specialized team for pain management and palliative care. So I'm glad to say that I'm a part of that team in my hospital. So we will see how palliative care can be implemented to a patient who is suffering from a serious illness. We'll see what are the aspects of palliative care or how we will implement the palliative care through our transcultural practices. So, what are the aspects? We focus mainly on symptoms and sufferings. The patient who is suffering, example, they are suffering from the cancer, so they'll be having a very disgusting symptoms like nausea, vomiting, diarrhea, or any kind of illnesses. So we have to focus symptoms and to avoid their sufferings. The next point is holistic approach. Holistic approach is nothing but overall well-being that include physical and emotional, spiritual, etc. We have to support and respect all their needs to improve the quality of their life. Next is team-based care. As I told you, we have a specialized palliative team. So those team include doctors, nurses, pharmacists, and chaplains, or any dignitaries who's dedicated to palliative care. So we should have a plan, and it is a teamwork, and it should be implemented effectively to patient's life. The important point is availability. Our availability should be there in each patient's life. So let us see United States of America. They have a very established palliative care for the patients. So there, a specialized team, they will be available in all needs of patient, and there have many type of practices to improve the life of the patient, improve the quality life of the patient. So why we have to give palliative care? Or else patient is coming to the hospital and we are giving care. I'm telling you an example, cancer. Why? Because cancer patient needs palliative. They are the one mainly going for palliative care. So, but palliative care doesn't mean that only for the cancer patients. It can be happen in any stage of life, either pediatric or geriatric, or the youngsters. So, what is the benefit? Why palliative care? It is enhancing well-being and support for families. If a patient is affected or a patient is in palliative stage or nearing to death, end of their life stage, how their families will be. Their system will be completely disturbed. So we have to give support patient as well as the families. So recognized care plans. We should have a specialized plan, well care plan or a care plans should be there. As nurses, we are mentioning care plans for each diseases or diagnosis we are preparing through care plan, and we are the implementation is there. So implementation column, what we used to do, we are providing the plan how to implement the system to the patient, and all over thereby improve the quality of the life. So these are enhanced well-being, support for their families, and we are preparing the care plans which helps the patient and thereby improve the quality of their life. Here, what are the global palliative care crises, or what are the limitations according to WHO? Only 12% of the global palliative care needs are met. You can imagine that only 12% of the needs in some countries, maybe like UK or USA, the countries which is financially high when compared to other countries, they are providing all the needs of palliative care for all the patients. And 64% of the countries have extremely limited or no services at all. Certain parts of Africa will comes under this country, these countries, and you can imagine that 64% of their communities lagging palliative care resources, and 75% of the unmet needs in that low and middle income countries, including our country, which is middle income country, and low income countries also comes under this group. So 75% of the globally palliative care needs are not met. So we can see by 2060, the studies show that it projected 87% increase in needs by 2060. So during this period, we have to the countries should have a specific or holistic approach to palliative care to improve their needs. Then only we can uh, decrease this ratio and to avoid unmet needs. So we will try for the better palliative care, and these are the current crises which global palliative care faces. Let us begin what is transcultural nursing. I'm here to talk about transcultural nursing. It is a branch of nursing that focuses on understanding different cultures and providing care that respects patients' cultural beliefs, values, and practices. It aims to deliver culturally sensitive and appropriate healthcare to people who diverse background, ensuring better communication, comfort, and healthcare outcomes. So transcultural nursing is nothing but it is a branch of nursing. So it differs from countries to country, setups to setup, etc. So transcultural nursing practices we are following to improve the palliative care. So it is interconnected. And let us talk about the photo, the picture you can see who's the founder of transcultural nursing, Mrs. Madeline Leninger. She was an American nurse, anthropologist, and educator who found the policies of transcultural nursing. So, transcultural nursing, how it is important in palliative care. As I told you, palliative care begins significantly more effective when informed by transcultural nursing policies and practices. So we have to practice transcultural practices. We'll see what is practices and policies of transcultural nursing. thereby improve the quality of our palliative care patients. So we'll see what is the transcultural nursing practices. Practices means what? We are providing, how we are providing the care to the patients. So providing individualized care. We are focusing to a particular patient to provide their quality of their care. So we are focusing a specialized team who's assigned for a single patient to provide maximum care and to meet maximum their needs to alleviate the symptoms and sufferings. So the second point is understanding cultural background of the patient. Cultural background, example, I can explain you that if a patient belongs to a community of Muslim, say they would like to have halal meat while during their hospital stay. So we have to inform that to dietary departments so that patient will eat comfortably and they will be having means they will get much comfort. So respecting patients' beliefs. This is the same point, almost same, that we have to respect their beliefs. And if example, in clinical setup, you can say that this is the rounds time, so you have to avoid your prayer. No, it's not possible. Countries like Middle East, they have 4 or 5 prayer times are there for the Muslim community. So they will be, they have to give we have to provide the respect towards their cultural beliefs. And we have a special timings to meet their rounds, doctors' rounds. So thereby we are respecting patients' beliefs and ensure patient comfort. All of these needs will meet patient comfort and aligns preferences of symptom management. As I told you, how we are focusing on symptoms and how we are managing the symptoms, that through transcultural nursing practices. And effective communication should be there. There should not be any language barriers. So effective communication implies that example, a nurse who's working in a United States of America or any other country, apart from your country. So, a patient who you are meeting a patient with another language. She can only communicate with you in other language. Example, I can give you that during my clinical practices, I remember one patient. I was a staff nurse in oncology ward that time. So that time I met a patient who's from America. I'm sorry, Africa. Sorry. So that patient only can communicate in their regional language, and none of us knows that language. So we tried to seek help from a translator, and after that, patient started feeling comfort, and he was peaceful. The first day I met him in a very stressful manner, and he was throwing the things. So we don't know what is happening, and we don't know how to communicate with him. So we appropriate time we seek helps. Thereby we improved. We meet the needs of that palliative patient. He was actually suffering from multiple myeloma with such a great pain. So effective communications plays an integral role. So there how we are overcoming language barriers. If we doesn't know, we have to seek help from the interpreters or any other translators. Engaging with patients and families. Countries like United States, well, I told you, we have a special team and going to the community setup. So we had to interact with their families, then only we will come to know that what is their cultural beliefs, practices, what all we are explaining. So we have to engage with their families, thereby we will know their preferences. We'll see what are the policies of transcultural nursing. So it belongs to any type of nursing or any section of nursing, we have policies. So then only the care will be implemented effectively. So in that first, cultural awareness. Cultural awareness is understand the respects of patients' cultural beliefs and values. Effective communication, use interpreters and culturally appropriate communication methods. Respect for diversity, treat all patients equally without discrimination. In USA, you can meet around more than 60, uh, 60 groups of languages are available, regional languages. So, if a patient is coming to your hospital or your clinical setup, you have to treat every patient as same, and our care should be implemented in an effective way for all. Patient-centered care. It involves patients and their families in decisions according to their culture. Holistic care addresses, I told you, holistic approach is the overall well-being. So physical, emotional, spiritual, and cultural aspects of health. Education and training. We train the nurses to provide the culturally sensitive care. Advocacy. Support and protect patients' cultural rights in healthcare. And what is ethical practice? Maintain ethical standards while respecting the cultural differences. So, global access to transcultural nursing. It means providing culturally sensitive care worldwide, ensuring patients from diverse cultural and linguistic backgrounds receive respectful and appropriate health care. So this is nothing but many countries have different transcultural practices. So we will see certain countries and how their care is implementing. Medical tourism, which is found in India and Thailand. Nurses provide care for international patients considering language, diet, and cultural practices. Refuge health care we can found in Europe and Middle East. Nurses assist refugees by using interpreters, offering mental health support, and designing culturally suitable care plans. In India and Thailand, we are going to considering language, diet. We are going to their community setup, and we are finding their language, diet, and cultural practices. Thereby, we are giving them care in that way. Whereas Europe and Middle East nurses assisting the refugees to use interpreters to communicate in their language, offering mental health support and designing culturally suitable care plans. And Australia and Canada, nurses programs respect traditional healing practices while integrating modern medicine. So they are integrating by modern medicine, and thereby they are practicing in indigenous healthcare. International Nursing Exchange Program, which is found nurses train and work in their countries to learn different cultural norms and providing culturally appropriate care. So, what are the challenges in transcultural nursing practices? Cultural beliefs. Diverse cultural beliefs shape perceptions of death, pain, and disclosure of terminal illness, directly influencing patient and their choices. So cultural beliefs are different from each patients are coming from each family setup. So their culture will be different person to person. So we have to find out and to provide maximum care. And second point lies to communication barriers. Usually, as I told you, the communication barriers are it will give much challenging job for the nurses. Language barriers and differing from family roles, complete communication and care planning, necessitating culturally sensitive approaches. So we have to deplete the communication barriers by keeping some translators. deficiency of opioids. This is one of the very important point, and this is a main crisis. The countries like Australia, very poor countries like Africa or Nigeria, they are mainly facing deficiency of opioids. Restrictive regulations and stigma limit access to essential pain medications. Essential pain medications such as morphine, oxycodone, and pethidine, whatever the patient who's using in serious suffering illnesses like cancer and any other lifelong diseases, or any other diseases like diabetes mellitus, cardiac issues, any type of diseases, they are finding the scarcity of opioids, causing immense, and they are suffering immensely. Why? Because they are having a very limited access and workforce shortage. I told you we should have a specialized team for implementing the palliative care system. So there, the workforce is very short, and they don't have access to provide more staff for the particular provide to the particular team. So critical lack of trained palliative care professionals and interdisciplinary teams persist, especially in resource and poor settings. So they are having a critical lack of trained palliative nurses. Thereby, the system will be it is very difficult to implement to patient and patient centered care. So there are some progresses happening in transcultural nursing practices. We can see in United Kingdom, this is the first hospice movement, which is and UK is the one of the best, one of the first countries in who implementing palliative care in a very effective way. And whereas Uganda is the first African country to allow nurses to prescribe morphine for the cancer patients. And in India, provides community-based palliative care. And we are proud to listen that is from Kerala and through Kerala model. Latin America, growing regulations of palliative care into cancer treatment. So in this slide, we can see that how a patient with the means before access to transcultural nursing and after access to transcultural nursing. If you can see in this picture that a patient is in clinical setup or in hospital or home, wherever, and no one is there with them, and no care is implementing. So it is very difficult situation, and they are suffering. This is the end of their life stage. Whereas in other pictures, this person is very happy, and how they are surrounding to the healthcare professionals. And this is what we are nurses, and we can provide maximum care for their improving the quality of care in this stage. So every one of us should try to achieve the smile in their faces. Okay, so let's see. Before concluding the topic, I would say thanks to each dignities of Pushpagiri Nursing College, especially principal and management. And special thanks to my colleague, Mrs. Maya Mol Matthew, one of the faculty of Pushpagiri Nursing College. So thank you one and all. And let's conclude what is the responsible transcultural nursing. Transcultural nursing and palliative care, it is interconnected. So we are improving the palliative care through our transcultural nursing practices and policies. So as nurses, we are the heroes, and we are the one provide. We are the one. We place a key role in transcultural nursing practices, thereby improving the patient's standard of their end of life stage. So transcultural nursing helps nurses to understand different cultures and provide patient-centered care that respects beliefs, values, traditions. thereby leading the better healthcare outcomes. So thank you one and all. Thank you, dear student. Have a better studies, and I'm wishing you everyone. Thank you. Thank you so much.
We sincerely thank you, ma'am, for sharing your valuable insights.
I would like to invite the next presenter, Ms. Ashley Babu, to present their patient.
Good morning all, myself Ashley Babu. So today I'm going to present my case on synovial sarcoma. So synovial sarcoma is a rare and aggressive type of soft tissue cancer that arises from the mesenchymal cells and can differentiate into the tissues resembling synovial tissues, mainly occur in the bones, joints and tendons. So it is a rare and aggressive type of cancer, mainly occur in young adolescents of age group of 15 to 40 years, and it accounts for about 15 to 20% of the total soft tissue cancers. So moving on to the patient details, as a part of my clinical posting, I got admitted to the pain and palliative unit of Pushpagiri Medical College Hospital. Then and came with the patient, Mr. Pranav, 24 years old male, admitted in Pushpagiri Medical College Hospital on 30th of June 2025 with chief complaints of pain in the oral cavity and whitish discoloration and patches all over the gums. So the patient consulted Dr. P.T. Thambi, consultant of Palliative Care Pushpagiri Medical College Hospital and newly diagnosed as gastritis. So the patient is a known case of synovial sarcoma since 2022, diagnosed at Kottayam Medical College Hospital after taking biopsy from an abnormally enlarging mass present on the right forearm. Then the patient undergoes right forearm amputation due to the metastasis of synovial sarcoma. Moving on to the family details, the patient's family consists of 4 members and the patient had a family history of stomach cancer, that the patient's grandmother is a known case of stomach cancer since 5 years. So the personal history, the patient maintains a normal bladder and bowel pattern and the normal diet pattern, no specific allergies. The physical examination shows the patient is very weak and tired, and also the local examination shows unsymmetrical upper extremities due to the amputation of right forearm. So the treatment done was, the patient had undergone radiotherapy in 2022 and chemotherapy, 5 cycles of chemotherapy has done, and the patient is on supportive therapy in pain management by using tapmorphine 20 mg. Then the investigation shows the increased. Moving on to the nursing diagnosis. The nursing diagnosis includes acute pain all over the body related to the metastasis of synovial sarcoma and impaired physical mobility related to right forearm amputation as evidenced by difficulty in doing daily activities, and also imbalanced nutritional status, less than body requirements, related to less intake of food as evidenced by, related to loss of appetite as evidenced by less intake of food, and also ineffective coping related to potential side effects of treatment as evidenced by anxious facial expression. So as a conclusion, nursing care was given based on the identified needs and problems. And also now the patient's condition got improved and doctor planned for discharge. So this is all about my patient's condition. Thank you.
Thank you, Ashley, for the presentation. I would like to invite the next presenter, Ms. Neha Kini, to present their patient.
So good morning all, dear dignitaries, faculties and all my dear friends. Today I am going to present on the topic that is laryngeal cancer. Coming to the introduction, laryngeal cancer is a malignant tumor that arises from the tissues of the larynx, and it is most commonly from the squamous epithelial cells. It's more common in men than of women. Coming to the biographic data of the patient, my patient's name is Mr. X of 72 years old male patient, was admitted in Pushpagiri Medical College Hospital on 17/8/2025, came now with the chief complaints of breathing difficulty, and he consulted Dr. Anuja Rajan and is diagnosed as acute exacerbation of COPD. The present medical and past medical history of the patient. Present medical history of the patient. My patient is of 72 years old male patient, admitted with the chief complaints of breathing difficulty. Then past medical history, he is a non-case of CA larynx since 3 years, and he was diagnosed at Kottayam Medical College Hospital. Okay. He had undergone 4 cycles of chemotherapy that was on cisplatin and is now undergoing radiation therapy. And at the time of diagnosis of CA larynx, the patient was presented with the chief complaints of hoarseness of the voice and also difficulty in breathing, which is signs and symptoms of CA larynx. The treatment, the patient is now on the medication such as injection hydrocod 100 mg, that is a bronchodilator given for breathing difficulty. Then TAP Cilacor, which is antihypertensive. Then NEP Ibravet bronchodilator. Then TAP Tamiflu for antiviral. And his lab investigations were normal except ESR is increased to 28 mmHg. The normal value of ESR is 5 to 20 mmHg. Then the nursing diagnosis of the patient, impaired breathing pattern related to presence of secretions as evidenced by altered respiratory rate, ineffective airway clearance related to increased mucus secretion as evidenced by breathing sounds, imbalanced nutrition status less than body requirement related to loss of appetite as evidenced by less intake of food. Then last one, disturbed sleep pattern related to hospitalization as evidenced by frequent yawning. The interventions were given according to the identified needs and problems. The diet plan of the patient is currently on well-balanced diet, but as he is hypertensive, he is having a reduced salt intake, that is DASH diet. We all know that DASH diet is a diet approach to stop hypertension. Then I have provided health education to the patient based on the diet, that is to avoid cold and dry spicy food to avoid the triggering of cough. Then infection prevention, hydration to increase the intake of fluids. Then breathing exercise, I provided health education about the pursed lip breathing exercises. Then to lifestyle modifications. So this is all about my topic. My summary, the patient is of 72 years old patient with a non-case of CA larynx and admitted for the treatment of acute exacerbation of COPD. I provided adequate care according to the identified needs and problems. Then the patient is apparently well now than at the time of admission. He had discharged at 26/8/2025. His stay in the hospital was eventful. Thank you.
Thank you, Neha, for the presentation.
Up next, I would like to take this opportunity to thank our sponsors, the Solar Base team. They are a young team of engineers deeply passionate about renewable power generation. Their mission is to lead the renewable energy renovation by providing innovative and sustainable solar engineering and construction solutions that power a brighter and clean future.
എങ്കിൽ അത് 200 രൂപയാണ്. ഉണ്ടാക്കാനും KCB-യിൽ നിന്ന് ഇങ്ങോട്ട് പണം ലഭിക്കാനുള്ള ഒരു കിടിലൻ സൊല്യൂഷനുമായിട്ടാണ് ഞാൻ വന്നിരിക്കുന്നത്. നിങ്ങളുടെ റൂഫ് ടോപ്പിൽ ഇൻസ്റ്റാൾ ചെയ്യൂ സോളാർ പാനൽ. അതും 30,000 രൂപ മുതൽ 78,000 രൂപ വരെ ഗവൺമെന്റ് സബ്സിഡിയോടുകൂടി. പാനൽ ഇൻസ്റ്റാൾ ചെയ്യാനായി 7 വർഷത്തെ ഇൻഡസ്ട്രി എക്സ്പീരിയൻസും 1000-ലധികം സക്സസ്ഫുൾ പ്രൊജക്ട് കംപ്ലീറ്റ് ചെയ്ത സോളാർ ബേസ് ഉണ്ട്. അവരാകുമ്പോൾ ബെസ്റ്റ് ബഡ്ജറ്റിൽ സർവീസും പേപ്പർ വർക്കും പെർമിറ്റും എല്ലാം ശരിയാക്കി തരും. റിട്ടേൺ ഓൺ ഇൻവെസ്റ്റ്മെന്റും കമ്പനി ഒട്ടും സമയം കളയേണ്ട. ഇൻസ്റ്റലേഷൻ പ്രോസസ്സിനും ബാക്കി ഡീറ്റെയിൽസുമായി ഇപ്പോൾ തന്നെ സോളാർ ബേസിനെ കോൺടാക്ട് ചെയ്യൂ.
Now it's time for a short break. You all can have your tea and snacks. Please be back by 10:30. Thank you.
കച്ചവടമാണ് ഞാൻ. 2,000-4,000 രൂപയോളം വീട്ടിൽ വരുമായിരുന്നു. അതുകൊണ്ട് 1 lakh rupees തന്നെ ഞാൻ ബിസിനസ് ചെയ്യുന്നുണ്ട്. ഫ്രോസണിൻ്റെ ബിസിനസ് ആയതുകൊണ്ട് എനിക്ക് കോൾഡ് റൂം വേണം. 1 lakh rupees-ഓളം ഇവിടെ കറണ്ട് ചാർജ് വരുന്നുണ്ട്. അപ്പോൾ അങ്ങനെ ഇരുന്നപ്പോഴാണ് ഞാൻ ഈ സോളാർ ബേസിനെ പറ്റി കേട്ടത് അറിയാനിടയായത്. വെച്ചതിന് ശേഷം എനിക്കുണ്ടായ അഡ്വാൻറ്റേജ് എന്താണെന്ന് ചോദിച്ചാൽ വീട്ടിലെ കറണ്ട് ചാർജ് എന്ന് പറയുന്നത് ആയി. പിന്നെ കടയിലേക്കെന്ന് പറഞ്ഞാൽ അത് ഇവിടെ പ്രൊഡ്യൂസ് ചെയ്യുന്നതിന് കടയിലേക്ക് കൊണ്ടുപോകുന്ന ഒരു വീലിംഗ് ചാർജുണ്ട്, ചെറിയ എമൗണ്ടേ ഉള്ളൂ. അപ്പോൾ അത് കടയിൽ അതിൻ്റെ ഒരു അഡ്വാൻറ്റേജ് വെച്ചാൽ മന്ത്ലി 10,000 രൂപയുടെ കറണ്ട് ചാർജ് ലാഭിക്കുവാൻ സാധിക്കും. വീട്ടിലേത് 4,000 എന്നുള്ളത് ഏതാണ്ട് ഒരു 800 രൂപ താഴെയായിട്ട് ഭയം ഉണ്ടായിരുന്നു അങ്ങനെയൊക്കെയാണ് എന്തുവാണെന്നുള്ളത്. പക്ഷേ ചെയ്യാൻ തുടങ്ങിയപ്പോൾ എനിക്ക് മനസ്സിലായി നല്ല നല്ലൊരു സിസ്റ്റമാണ്, രീതികളും എല്ലാം എനിക്ക് വളരെ ഇഷ്ടപ്പെട്ടു. ടാക്സ് ചെയ്യുമ്പോൾ ഒരു പേടിയുണ്ടായിരുന്നു. അതൊക്കെ ഞാൻ പറഞ്ഞതിനെല്ലാം പുതിയ സിസ്റ്റത്തിൽ അല്ലെങ്കിൽ റിസൾട്ടും ഫില്ല് ചെയ്യാതെ ചെയ്ത് സാറ്റിസ്ഫൈഡ് ആണ്. ആയിട്ടുള്ള സിസ്റ്റമാണ് ചെയ്യുന്നത്. സംസാരിച്ചപ്പോൾ എനിക്കിപ്പം പുതിയതായിട്ട് ഇറങ്ങിയതിൽ ഇൻവെർട്ടർ സിസ്റ്റമാണ് അഡ്വാൻസ് എന്ന് മനസ്സിലായി. 1 lakh rupees എപ്പോഴും ഉണ്ടെന്ന് പറഞ്ഞു. പക്ഷേ എന്നിട്ട് ഞാൻ അത് തന്നെയാണ് ചെയ്തിരിക്കുന്നത്. ഇതുവരെ കുഴപ്പമൊന്നും നല്ല അഭിപ്രായമാണ് ഉള്ളത്. എനിക്ക് തോന്നുന്നു ഒരു ലാഭം എനിക്ക് ഉണ്ടാവുമെന്നാണ് നല്ല ഡീലിംഗ് കച്ചവടമാണ് ഞാൻ. 2,000-4,000 രൂപയോളം വീട്ടിൽ വരുമായിരുന്നു. അതുകൊണ്ട് 1 lakh rupees തന്നെ ഞാൻ ബിസിനസ് ചെയ്യുന്നുണ്ട്. ഫ്രോസണിൻ്റെ ബിസിനസ് ആയതുകൊണ്ട് എനിക്ക് കോൾഡ് റൂം വേണം. 1 lakh rupees-ഓളം ഇവിടെ കറണ്ട് ചാർജ് വരുന്നുണ്ട്. അപ്പോൾ അങ്ങനെ ഇരുന്നപ്പോഴാണ് ഞാൻ ഈ സോളാർ ബേസിനെ പറ്റി കേട്ടത് അറിയാനിടയായത്. വെച്ചതിന് ശേഷം എനിക്കുണ്ടായ അഡ്വാൻറ്റേജ് എന്താണെന്ന് ചോദിച്ചാൽ വീട്ടിലെ കറണ്ട് ചാർജ് എന്ന് പറയുന്നത് ആയി. പിന്നെ കടയിലേക്കെന്ന് പറഞ്ഞാൽ അത് ഇവിടെ പ്രൊഡ്യൂസ് ചെയ്യുന്നതിന് കടയിലേക്ക് കൊണ്ടുപോകുന്ന ഒരു വീലിംഗ് ചാർജുണ്ട്, ചെറിയ എമൗണ്ടേ ഉള്ളൂ. അപ്പോൾ അത് കടയിൽ അതിൻ്റെ ഒരു അഡ്വാൻറ്റേജ് വെച്ചാൽ മന്ത്ലി 10,000 രൂപയുടെ കറണ്ട് ചാർജ് ലാഭിക്കുവാൻ സാധിക്കും. വീട്ടിലേത് 4,000 എന്നുള്ളത് ഏതാണ്ട് ഒരു 800 രൂപ താഴെയായിട്ട് ഭയം ഉണ്ടായിരുന്നു അങ്ങനെയൊക്കെയാണ് എന്തുവാണെന്നുള്ളത്. പക്ഷേ ചെയ്യാൻ തുടങ്ങിയപ്പോൾ എനിക്ക് മനസ്സിലായി നല്ല നല്ലൊരു സിസ്റ്റമാണ്, രീതികളും എല്ലാം അഡ്വാൻസ്ഡ് ആയിട്ടുള്ള സിസ്റ്റമാണ് ചെയ്യുന്നത്. സംസാരിച്ചപ്പോൾ എനിക്കിപ്പം പുതിയതായിട്ട് ഇറങ്ങിയതിൽ മൈക്രോ ഇൻവേർട്ടർ സിസ്റ്റമാണ് അഡ്വാൻസ് എന്ന് മനസ്സിലായി. 1 lakh rupees ആൻഡ് എപ്പോഴും ഉണ്ടെന്ന് പറഞ്ഞു. പക്ഷേ എന്നിട്ട് ഞാൻ അത് തന്നെയാണ് ചെയ്തിരിക്കുന്നത്. പുഷ്പഗിരി ഇതുവരെ കുഴപ്പമൊന്നും നല്ല അഭിപ്രായമാണെന്നുള്ളത്. കാരണം എനിക്ക് തോന്നുന്നു ഒരു കുറച്ചൊക്കെ 2000 ലാഭം എനിക്ക് ഉണ്ടാവുമെന്നാണ് നല്ല ഡീലിംഗ് കച്ചവടമാണ് ഞാൻ 4,000 രൂപയോളം വീട്ടിൽ തരുമായിരുന്നു. അതുകൊണ്ട് 1 lakh rupees തന്നെ ഞാൻ ബിസിനസ് ചെയ്യുന്നുണ്ട്. ക്ലോസറിൻ്റെ ബിസിനസ് ആയതുകൊണ്ട് എനിക്ക് കോൾഡ് റൂം വേണം. അതുകൊണ്ട് 1 lakh rupees-ഓളം ഇവിടെ കറണ്ട് ചാർജ് വരുന്നുണ്ട്. അപ്പോൾ അങ്ങനെ ഇരുന്നപ്പോഴാണ് ഞാൻ ഈ ഇതിനെ പറ്റി കേട്ടത് അറിയാനിടയായത്. വെച്ചതിന് ശേഷം എനിക്കുണ്ടായ അഡ്വാൻറ്റേജ് എന്താണെന്ന് ചോദിച്ചാൽ വീട്ടിലെ കറണ്ട് ചാർജ് എന്ന് പറയുന്നത് കുറഞ്ഞു 2 ആയി. പിന്നെ കടയിലേക്കെന്ന് പറഞ്ഞാൽ അത് ഇവിടെ പ്രൊഡ്യൂസ് ചെയ്യുന്നതിന് കടയിലേക്ക് കൊണ്ടുപോകുന്ന ഒരു വീലിംഗ് ചാർജുണ്ട്, ചെറിയ എമൗണ്ടേ ഉള്ളൂ. അപ്പോൾ അത് കടയിൽ അതിൻ്റെ ഒരു അഡ്വാൻറ്റേജ് വെച്ചാൽ മന്ത്ലി 20,000 രൂപയുടെ കറണ്ട് ചാർജ് ലാഭിക്കുവാൻ സാധിക്കും. വീട്ടിലേത് 4,000 എന്നുള്ളത് ഏതാണ്ട് ഒരു 800 രൂപ ഇതായിട്ട് ഭയം ഉണ്ടായിരുന്നു അങ്ങനെയൊക്കെയാണ് എന്തുവാണെന്നുള്ളത്. പക്ഷേ ചെയ്യാൻ തുടങ്ങിയപ്പോൾ എനിക്ക് മനസ്സിലായി നല്ല നല്ലൊരു സിസ്റ്റമാണ് രീതികളും എല്ലാം എനിക്ക് വളരെ ഇഷ്ടപ്പെട്ടു. ചെയ്യുമ്പോൾ ഒരു പേടി ഉണ്ടായിരുന്നു. അതൊക്കെ ഞാൻ പറഞ്ഞതിനെല്ലാം പുതിയ സിസ്റ്റത്തിൽ അല്ലെങ്കിൽ ഡ്രിൽ ചെയ്യാതെ ചെയ്തത് സാറ്റിസ്ഫൈഡ് ആണ്. അഡ്വാൻസ്ഡ് ആയിട്ടുള്ള സിസ്റ്റമാണ് ചെയ്യുന്നത്. സംസാരിച്ചപ്പോൾ എനിക്കിപ്പം പുതിയതായിട്ട് ഇറങ്ങിയതിൽ മൈക്രോ ഇൻവേർട്ടർ സിസ്റ്റമാണ് അഡ്വാൻസ് എന്ന് മനസ്സിലായി. 1 lakh rupees ആൻഡ് എപ്പോഴും ഉണ്ടെന്ന് പറഞ്ഞു. പക്ഷേ എന്നിട്ട് ഞാൻ അത് തന്നെയാണ് ചെയ്തിരിക്കുന്നത്. പുഷ്പഗിരി ഇതുവരെ കുഴപ്പമൊന്നും നല്ല അഭിപ്രായമാണെന്നുള്ളത്. കാരണം എനിക്ക് തോന്നുന്നു ഒരു കുറച്ചൊക്കെ 2000 ലാഭം എനിക്ക് ഉണ്ടാവുമെന്നാണ് നല്ല ഡീലിംഗ് കച്ചവടമാണ് ഞാൻ കറണ്ട് ചാർജ് 4,000 രൂപയോളം വീട്ടിൽ തരുമായിരുന്നു. അതുകൊണ്ട് 1 lakh rupees തന്നെ ഞാൻ ബിസിനസ് ചെയ്യുന്നുണ്ട്. ക്ലോസറിൻ്റെ ബിസിനസ് ആയതുകൊണ്ട് എനിക്ക് കോൾഡ് റൂം വേണം. അതുകൊണ്ട് 1 lakh rupees-ഓളം ഇവിടെ കറണ്ട് ചാർജ് വരുന്നുണ്ട്. അപ്പോൾ അങ്ങനെ ഇരുന്നപ്പോഴാണ് ഞാൻ ഈ സോളാർ ബേസിനെ പറ്റി കേട്ടത് അറിയാം.
I request all the students to get into the auditorium.
So we will end up with this. Let us see. I stopped where there started culture, right? Culture is very important. I'll tell you one incident, what happened with me. Usually we do the last office for all the patients once they die, okay? But it's very important. Can we get? Hello? It's very important that we need to ask. That how I learned was, after the patient's death, we did everything, we wrapped also, okay? So we called the family member, he came inside and he just stood like this and he said, this is not the way. നമ്മൾ റാപ്പ് ചെയ്തപ്പോൾ പറഞ്ഞത് അയാൾ പറഞ്ഞു ഇങ്ങനെയല്ലായിരുന്നു എന്ന്. You know, when I heard about it, I felt little bad because അവരുടെ ഫാദർ ആയിരുന്നു അത്. അപ്പം അവരുടെ കൾച്ചർ എന്താണെന്ന് എനിക്ക് നമുക്ക് അറിയില്ലായിരുന്നു. Okay, so then I asked him, whatever you want to do, you can carry it out. So he removed whatever we have done. അതിൽ അവർ ഫേസ് പുറത്തേക്ക് ആക്കി, ഫേസ്, and കാലിൻ്റെ അവിടെ മാത്രം they just put this one, tie. That's all they did. They removed everything. So I learned one more thing. See, every person has a culture. Okay. It's not that in religion, Christian, Muslim, Hindu, like that. Even in there, caste-wise, there is a culture. Okay. So anything we do, please do ask them what we are doing is correct or wrong. Otherwise, ask them, come inside and ask them what we have to do it. So culture is also very important. You know, in some culture, they don't like to give blood. Okay. That is their culture. So anything we do, we need to ask them. Okay. Care of the imminently dying and ethical and legal aspects of the care. Okay. End of life care. I heard I had a friend from Switzerland. He had come down. So he took my interview about the this one, end of life here. Okay. So he asked, why people in India always start crying when the patient is dying, it seems. എനിക്കതിനൊരു ഉത്തരം ഉണ്ടായിരുന്നില്ല. ഞാൻ ആലോചിച്ചു, what is that? See, normally, കരച്ചില്ല. So he told me, when we are born, we are so happy. When we are born, എല്ലാവരും ലഡ്ഡു കൊടുക്കുന്നു, എന്തൊക്കെയാണുള്ള ചില ജിലേബി എന്താ ചാവട്ടെ, okay, they do it. But only when we die, why these people are crying, ഭയങ്കര കരച്ചിലാണ്. Suddenly something went inside my mind. Okay, so he was going to Chennai, Tamil Nadu. So I told him, his name is Clark. I said, Clark, when you go to Chennai, okay, you will see something entirely different. It's not all over in India, but in some places, after death also people dance around, I said. Okay, yeah, they are smiling, you know. So once he came back, he told me, he was going in the car, he saw a lot of flowers on the road, it seems. So he thought, some ministers have come, so they are throwing flowers. Once he crossed that, പിന്നിൽ തിരിഞ്ഞ് നോക്കിയപ്പോൾ കണ്ടതെന്താ, ഒരാളിങ്ങനെ ഇരുത്തിയിട്ട് വലിയൊരു കണ്ടിട്ടുണ്ടോ തമിഴ്നാട്ടിൽ, എന്താ പിന്നിലുള്ളവർ കണ്ടിട്ടുണ്ട്, ഇവിടെ ഒരു കോയിൻ വെക്കും മരിച്ച ആൾക്ക്, അയാൾ ഇരിക്കുകയായിരിക്കും, ചിലപ്പം ഇതൊക്കെ ഇടും കേട്ടോ, സൺഗ്ലാസസ് ഒക്കെ ഇട്ടിട്ടാണ് കൊണ്ടുപോവുക. എന്നിട്ട് എല്ലാവരും ഇത് ബാൻഡ് മേളായിട്ട് ചാടി ഓടിയിട്ടാണ് പോവുക. So he was very happy seeing that. At least people are very happy. Okay, so culture is very important. So dying, imminently dying patients, there are a lot of things which we have to talk about end of life care that we will do afterwards. So this is a supporting team to improve the quality of life. One is nursing education in palliative care, social work in palliative care, role of the chaplain in palliative care, which we don't have. In fact, in many of the hospitals, we don't have. Occupational therapy, physiotherapy, dietitian, the role of creative arts in palliative, especially for the children, pediatric group. Speech and language therapy when the patients are having tracheostomy and all. Clinical psychology in palliative care is very important because they need a lot of psychological support. And of course, the contribution of the clinical pharmacist and medical rehabilitation. Don't think always the patients come and die in palliative care. No, we do rehabilitation also for the patients. So all these things are very important. Now, the main thing is, any idea what it is? Heart, head and hands. In our life, these three things are very important. Our heart, which gives a lot of love. Our head, that's the brain, lot of knowledge. And the hand, that is the skill. If one is not there, it is not going to work. These three things you need. You need an attitude, you need the knowledge, and you need the skill, because these three are connected. If you don't have attitude, you have only the knowledge and the skill, patient is not going to get anything. You have the knowledge and you have the, you don't have the skill. What is the use? So all three things you need to take care of a patient and family. And this is my take-home message also for you all. We are going to come this back. So in advanced skills in nursing, these four pillars are very important. Clinical, otherwise direct care. Sanma was talking about the clinical diagnosis. You all should need a nursing diagnosis. Main diagnosis will be there for a patient. Suppose a patient has come with a stroke. His diagnosis is stroke. But what will be your clinical diagnosis? His problems. Okay? Leadership and collaborative practice. You should have that leadership quality in you. To lead the team, to lead a home care. If suppose tomorrow you are going to be the ward in charge, you know how to lead your group, your subordinates. And of course, it should be collaborative also. Do have collaboration with everyone. You alone cannot do things. You need to collaborate with all the departments. Improving quality and developing practice. Improve the quality of whatever you are doing. New technology is coming, but still, as a nurse, this is needed. Without hand, you cannot do anything. Recently, I have attended one AI program. It was done by an anesthetist holding a PhD in AI in one of the leading universities. She told me something. She said, in medical system, if AI comes, what will happen? So the heading of this one, AI death. Okay. So we all thought, what is that AI death? Because nowadays people all are talking about AI only, right? And if you ask me, I don't know anything about that. Okay, don't ask also. So, you know what happened? She talked about the advantage, everything she talked, but she talked about the disadvantage if it comes to the medical system. So, one person said he has seen all the doctors and all. He's so stressed, so much of tension because of the workload. So he's asking the AA, what should I do? You know what the AA said? We could hear clearly, die, die, die. Very easily. And another second thing was about a diagnosis which was given by the doctor. The AA is telling this diagnosis is not correct. This is the diagnosis it's saying. It was really shocking. The doctor was telling it was really shocking why people are thinking about AA in medical system. Everything will go up and down. It's not right, she said. She told. So we were sitting and talking. I said, thankfully nurses only have to do. I don't think AA can come and do. Recently they are going to have some robots, no? But a touch of a robot and a touch of, is there a difference? There will be a difference. There is a difference. Okay. So developing self and others. if you feel your junior, others your seniors, having some lacking in their knowledge, in their skill, teach them. Okay? So, this is the trajectory of the chronic illness. Some people die immediate, sudden death. Yeah. Sudden death. Second one is cancer. They go slowly, they goes off. Third one is up and down. You know, COPD patients and all going, coming in the hospitals. Another one is frail, old age and dementia. Okay. How do you like to die? How many want to die sudden? Nobody. Well, good. It is there. You. Only one person. So rest all of you, one more person. Rest all of you want to go and lie down in the hospital. Go, come and die. Thankfully, I won't be there to take care of you all. You also people want to be in the ICUs and all, huh? No. Only 2% said sudden death. So I want to ask a question to them. Suppose this happens now. Is it okay? Suppose you die now. No. You're okay with it. Now, pattan marichu poyam okay aano adile ado vende. Okay ana. Okay ana. That's very nice. Because avarku oru aagrahangalum illa. Usually when I take sessions, even the doctors, Adim Mario, sudden death is good. After that, if I ask, they will tell, no, not now. Then I will ask, when? After my studies finish, I have to get a job, I have to do my PG, I have to do my MCH, then I have to get married, I have to go abroad, I have to buy a car, I have to buy a house, then my children should grow, avaru padikkanam, angana apply etra vayasai 80 vayasai. Okay. Why I am talking about this? When we talk to the patients also, many patients they say, Maricha Madi, I don't want to leave. You ask them again, appa endu parayunnariyo? Pattathathondu parayunna. Allande marikkanamnilla aagraham illa. Then comes next, what you know, maybe a pain, otherwise my daughter's marriage, my son's studies, education, angana kore karyangal undavum. Understand? So nobody wants to die soon. But this side, can you imagine? Imagine holding the glass of water. How long you can hold a glass of water in your hand like this? One manikkur pidikkan pattumo? Half an hour? Maybe, right? But 15 minutes itself holding like this will give you pain, right? What it says, you know? Can you imagine and tell me why it is been shown there? What happened there? Let it go. You cannot hold someone's life for a long time. Let it go. So it is holding like a glass in the hand. We cannot hold anyone's life for a long time. We have to, at one point, we have to let it go. And that's why we say, in emergency and all, of course, we agree we have to put the patient on a ventilator, maybe patient is in ICU. We have to carry out a lot of things. But when a patient is chronically ill, where there are no chances and nothing is there, please don't give any futile treatment for the patient. There is no use just dragging their life. Once you all start your career, you have started your career, but what I mean is after finishing sometimes it will hurt you inside when you see some patients are just dragging on the ventilator. It will really pain you inside. It really hurts. Okay, so at one point you have to give. So we are going to come to this. The domains, physical, psychological, social and spiritual are the domains of palliative care, what we say the concept. Okay. I have something to show you. I really liked, thank you all so much. You have done a very good work outside. In fact, no need of telling Dame Cicely Saunders is the founder of modern hospice and all, because you have done everything outside. But you all know, I hope you all know, Dame Cicely Saunders was a social worker. Then she became a doctor and a nurse. Because she knew that people are not doing good to anyone. That's why she became 3 in 1. Okay? So that is it. I'm not going into that detail. This everything is being put over there. Just now I saw that and I liked also. So, this one. You matter because you are you. You matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. So that is quality of life. Till the end, my quality of life should be on the upper side. I should feel that I am living, even though I am having many disease or I am suffering also, but I should feel that I am living. Take home, bring together the heart, the head and the hand. And if you have these 3 things, you will be the best nurse to work. You will be the best nurse, the people will know about you. Okay, thank you. We'll continue with the next one. Slide. So, compassionate symptom support and understanding of the whole person. Okay, it is more of like symptom assessment. What happens in a hospital is, we usually look at the patient as a disease. We don't see that person as a person. We are more worried about their disease, we are more worried about their treatment. We are not worried about that person. Okay, so let us have a look what we can do for them. So Emma, when we do an assessment, this is very important. Evaluation, explanation, management, monitoring and attention to the details. I'll just talk to you all about this. What's the cause of the symptom you have to evaluate? Cause of that symptom. For as I told you, even if it is a stroke, why the patient developed a pressure ulcer? We need to know the cause. Aggravating and the relieving factors. I'll be coming to the acronym, we will see that. Okay, what are the aggravating factors for that? What could be the relieving factors? Like aggravating factor, because the patient is always in a supine position, patient developed a pressure ulcer. Now, what will be the relieving factors? We can put a water bird, changing position, these things. Okay? Pourable underlying pathological, any mechanism is there. See, just because of only the supine position won't cause. Some pathological things can change. Our physiological changes can do it, right? Okay, bad nutrition, okay, not taking care properly, any microorganisms, something can happen. And of course, what has been tried and failed. If you have tried some management, and whether it has been good or bad, means it has failed. And of course, what is the impact of the disease on the daily life? I'll come back to this. Explaining in simple terms is very important. I'll be talking about this in communication also. Whatever you explain to the family member, explain to them in very simple terms. Don't use any medical terms. That is very important. I'll give you an example also again now. From the department, medical department, patient was sent to the X-ray department. This ശരിക്കും കേൾക്കണം കേട്ടോ. Patient was sent to the X-ray department. It was written PUS, diagnosis. PUS with GOO. Any idea what it is? X-ray department എഴുതിയ നമ്മൾ സാധാരണ എക്സ്റേ ഇത് എഴുതുമ്പോൾ ഡോക്ടേഴ്സ് എഴുതില്ല ഡയഗ്നോസിസ്. അപ്പോൾ അവിടെ എഴുതിയതാണ് PUS പിന്നെ with GOO എന്ന്. ഓക്കെ, എക്സ്റേ ഡിപ്പാർട്ട്മെൻറ്റിൽ പോയി ദേ ഹാവ് ടേക്കൻ ദ എക്സ്റേ. ഓക്കെ, അവർ റിപ്പോർട്ട് കൊണ്ട് തിരിച്ചു വന്നപ്പം അതിൻ്റെ അകത്ത് എന്താ എഴുതിയെന്നറിയോ? MOO എന്ന്. എന്തായിരുന്നു എന്നറിയാം? PUS പെപ്റ്റിക് അൾസർ സിൻഡ്രോം. GOO എന്താണ്? ഗ്യാസ്ട്രിക് ഔട്ട്ലെറ്റ് ഒബ്സ്ട്രക്ഷൻ. അവരെന്താ അയച്ചെന്നറിയാം? 3 പറഞ്ഞിട്ട് മിഷൻ ഔട്ട് ഓഫ് ഓർഡർന്ന്. സോ സിമ്പിൾ ടേംസിൽ എക്സ്പ്ലെയിൻ ചെയ്യണമെന്ന് പറയുന്ന വൈ മെനി ഓഫ് ദ ടൈംസ് പേഷ്യൻ്റ് ദിസ് ഹാസ് ഹാപ്പൻഡ്. ഇത് ഞാൻ കളി പറഞ്ഞില്ല, RCCയിൽ നടന്ന ഒരു കാര്യമായിരുന്നു. ഓക്കെ, സോ Dr. Cherian Koshi used to always give this example. Be very careful about the terms that you use for the patient, because patients doesn't know any medical terms. Okay, simple explanation. And why the patient is feeling this particular symptom, feeling of the control over the symptom, or better complaints to the treatment. We need to ask why the patient is feeling that symptom. Discuss the treatment options, not the solution for you. You can say surgery, you can say some radiotherapy, chemotherapy, whatever it is. These are the options, but you need to explain the options also. But who has to take the decision? The patient and the family has to take the decision. Otherwise, tomorrow they will say, you told me to do the surgery, I have done the surgery, this is what happened. Management, correct the correctable. What could be corrected? Correct it. Pressure ulcer can be corrected, right or not? We can correct it, right? Okay. Use non-drug also as well as treatment. Many non-drug treatment management is there that we can use. Now I am having a very bad cold. Okay, I can take a simple steam inhalation. Okay, so like that, non-drug treatment is very important. Prophylactic drugs for persistent symptoms. In palliative care, we see that if the patient is having a persistent, any symptom is there. Like some patients, usually when they go to the washroom, they will start having pain. So prophylactically, we used to give some drugs that the patient is asked before going to the washroom or before moving out, better to take that medication so they won't feel pain. This concept of total care, we were talking about the personhood. Physical, psychological, social and spiritual. It should be a total care of the, not only physical, which happens in a hospital. We only focus on physical problems. We don't focus to the patient's psychological, social and spiritual or financial, even if I'll tell you. You are asking your patient to buy some medication. I know you will give the prescription to the patient and you will tell him, medical college vere nadakkunnadana. Okay, but we'll never ask them, do you have the money to buy it, or how you are going to manage it? See, you are not going to give, നിങ്ങൾ 10 രൂപ കൊടുക്കൂല, പക്ഷേ അതിലൊരു ഇമ്പോർട്ടൻ്റ് എന്താണെന്നറിയോ? ഞാൻ ചോദിക്കുകയാണ് നിങ്ങളുടെ അടുത്ത്, എങ്ങനെയാണ് ഇത്രയും പൈസ ഒപ്പിച്ചത് ഇത് വാങ്ങാനെന്ന്. That one question makes them happy. At least you have that concern that you ask me how I am going to make. Like you people all are studying here, I don't know, you all must be paying, right? Anytime you ask your parents from where they are making the money to teach you, giving the education? ഇതിൽ പലർക്കും maybe your families NRI ഒക്കെ ആയിരിക്കും. അതിലല്ലാത്ത ആൾക്കാരില്ലേ, ആരെങ്കിലും കടം വാങ്ങിച്ചു തരിക, അതുപോലെ എഡ്യൂക്കേഷണൽ ലോൺ. Now who is paying that education loan? Parents are paying, right? So it is just a simple example. You have to think about the patient and the family. Be specific in instructions. Before food, after food. Pharmacy, when you go and get medications, what they write? ഒന്ന് വീതം 3 നേരം എന്ന് എഴുതും. കണ്ടിട്ടില്ലേ? അങ്ങനെയല്ലേ എഴുതാറ് അല്ലേ? ഗുഡ് ഫാർമസിസ്റ്റ് they will write 1 വീതം 3 നേരം എഴുതിയിട്ട് they will write the timing എഴുതി തരാറുണ്ട്. ഓക്കെ, now പേഷ്യൻസിനെ സംബന്ധിച്ചോളം വാട്ട് ഇറ്റ് ഈസ്, 1 വീതം 3 നേരം 8 മണിക്ക് എടുത്തു, 12 മണിക്ക് എടുത്തു, വൈകുന്നേരം 4 മണിക്ക് എടുത്തു. They don't know the timing. So be specific about the instructions what you are giving and never say there is nothing to be done. ഒരിക്കലും ആരോടും പറയരുത് ഇനി ഒന്നും ചെയ്യാൻ ഇല്ല എന്ന്. ബിക്കോസ് ലോട്ട് ഓഫ് തിങ്സ് ആർ ദർ സ്റ്റിൽ വി നീഡ് ടു ഡു. ആൻഡ് മോണിറ്റർ. You have given a medication for the pain, monitor that. After about 45 minutes, go ask the patient, how is your pain now? മരുന്ന് തന്നിട്ട് എങ്ങനെ കുറഞ്ഞോ ഇല്ലയോ? We need to find out. Each shift when you take over, see that you are taking each patient properly. Then you will come to know what is happening with the patient. You need to know each of your patient by name, not with their diagnosis. Side effects. If they're taken some medication, whether they're having any side effects. In our time, we used to give sorbitrate. First question we will ask the patient is after 40 minutes, we'll go whether they're having headache. One of the side effects of sorbitrate is headache. Many of them, they don't know. Patient will come and complain headache. So in meantime, when we give also, we tell the patient, after taking them, you will may have a headache. Okay. And yeah, titration. You know, corticosteroids, usually we titrate it. We have to titrate. So when you explain it also, even when you give some medication, titration you have to keep in your mind. So I will leave this. I'm coming to the proper one. So symptom control is a key component of the comprehensive palliative care. And we have to take the data from the patients properly. Okay. So assessment is very important. Assessment should be in a quiet place, but in a general ward, it's very difficult. Okay. But at least you can do it. Sit near the patient, do a proper assessment, physical problems, psychological. But remember one thing, priority is to the patient. If you're sitting with the patient and the patient is saying, ഞാൻ രാത്രി ഉറങ്ങിയില്ല, എന്താ നമ്മൾ ബുദ്ധിമുട്ടെന്ന് ചോദിക്കൂ അല്ലേ? നെവർ ആസ്ക് ദ പേഷ്യൻറ്റ് ഇപ്പോൾ വേദന എങ്ങനെയുണ്ട് ചോദിക്കാൻ നിൽക്കരുത്. എന്താണ് നിങ്ങളുടെ ബുദ്ധിമുട്ടെന്ന് വേണം ചോദിക്കാം. വാട്ട് ഈസ് യുവർ പ്രോബ്ലം? ഓക്കെ. സം ഓഫ് ദ പേഷ്യൻറ്റ് വിൽ ഓപ്പൺ അപ്പ്. ചില പേഷ്യൻറ്റ് തുടങ്ങുന്നത് എങ്ങനെയാ അറിയോ? 2 ദിവസമായിട്ട് ഉറങ്ങിയിട്ടേ ഇല്ല. എന്ത് കാരണം ഉറങ്ങാഞ്ഞ്? സോ ലോട്ട് ഓഫ് തിങ്സ് ആർ ദർ. വൺ, ആർ യു സ്ലീപ്പിംഗ് ഇൻ ദ ഡേ ടൈം? ഓട്ടോമാറ്റിക്കലി നൈറ്റിൽ ഉറക്കം ഡിസ്റ്റർബ് ആവും, റൈറ്റ്? Now the second thing is, are you worried about something? Some patients they say, രാവിലെ ഉറങ്ങൂല രാത്രി ഉറങ്ങൂല. വൈ? രാത്രി ചിന്തയാണ്. സോ ഞാൻ 2-3 നടന്ന കാര്യങ്ങളാണ് പറയണത്. സോ ദാറ്റ് you remember more about it. I asked the patient, why you are not sleeping? പേഷ്യൻ്റ് പറഞ്ഞു ഭയങ്കര ചിന്തയാന്ന് പറഞ്ഞു. ഞാൻ പറഞ്ഞു എന്തിനെ പറ്റിയിട്ടാണുള്ള ചിന്തയാണ്? പറഞ്ഞു ഫാമിലിനെ പറ്റിയിട്ടുള്ള ചിന്തയാണ്. ഞാൻ ചോദിച്ചു ഫാമിലിനെ പറ്റിയിട്ട് എന്താ ചിന്ത? അവർ പറഞ്ഞത് എന്താ അറിയോ? ഇവരെല്ലാവരും, എൻ്റെ ഒരു സിസ്റ്ററുണ്ട്, അനിയത്തി, ജോലി വിട്ടിട്ട് എന്നെ നോക്കുകയാണിപ്പം. ഞാൻ കാരണം അവരുടെ ജോലി പോയി. അപ്പം ഞാൻ ചോദിച്ചു എപ്പോഴെങ്കിലും അവരങ്ങനെ പറഞ്ഞിട്ടുണ്ടോ നിങ്ങളോട്? ഇല്ല. സോ ഐ കോൾഡ് ദ സിസ്റ്റർ. I asked her, how do you feel taking care of your sister? She said, we all have been taken care by her only. ഞങ്ങളിപ്പോൾ ഈ സ്ഥാനത്ത് നിന്നുണ്ടെങ്കിൽ it was just because of her. So now it is our turn to take care of her. She was diagnosed with CA breast. Okay, now we are taking care of her. And we are happy that we are able to take care of her. So I just told her, her name was Sarojini. Sarojini ചേച്ചി കേട്ടല്ലോ എന്താണ് പറഞ്ഞതെന്ന്? Another patient, she said she cannot sleep in the night. I asked why. എന്താ പറഞ്ഞതെന്നറിയോ? ഞാൻ കണ്ണടച്ച് പോയാൽ ശ്വാസം വലിക്കാൻ മറന്നു പോവും. So what will happen to me? I will die. See, അതാണ് പേഷ്യൻസിൻ്റെ ചിന്തകൾ നമ്മളുണ്ടല്ലോ. സംടൈംസ് she told me, കണ്ണടച്ച് കഴിഞ്ഞാൽ ഞാൻ ശ്വാസം വലിക്കാൻ മറക്കും, അപ്പോൾ ഞാൻ മരിച്ചു പോവില്ലേ? So what happened? Whole night she is awake. Okay, so I just sat for some time. പിന്നെ ഞാൻ മെല്ലെ ചോദിച്ചു, എന്നിട്ട് ഞാൻ ചോദിച്ചു, സരളച്ചി ശ്വാസം വലിക്കുന്നത് അറിയുന്നുണ്ടോ എന്ന്. അപ്പോൾ എൻ്റെ മുഖത്തേക്ക് ഇങ്ങനെ നോക്കിയിട്ട് ഇല്ല, ശ്വാസം അറിയാണ്ടല്ലേ നമ്മൾ വലിക്കുന്നത്, നമ്മളറിയാണ്ടല്ലേ നമ്മൾ വലിക്കുന്നത്. അപ്പോൾ ഞാൻ ചോദിച്ചു, അപ്പോൾ ഇപ്പം എന്തായിരുന്നു? Why is it? Because she is suffering from CL lung. So what she felt is, ഞാൻ ഉറങ്ങിപ്പോയാൽ ഞാൻ ശ്വാസം വലിക്കില്ല, ഞാൻ മരിക്കും. അതവരുടെ പേടിയാണ്. So some patient don't think they will start with physical problems. They may start with their psychological problem. The only thing is we need a question in us to ask them. അവരുടെ ചിന്തനെ പറ്റിയിട്ട്. Okay. So assessment, communication with the patient is very important. Then only you can assess the patient. So symptom assessment, I'll come to the next one. Symptom assessment has two divisions. One is symptom occurrence, another is symptom distress. Symptom occurrence. So I'll tell you, I'm suffering from bronchial asthma. Think like that. That is my disease, right? What will be my symptom? Breathlessness will be my symptom. Okay. So if I have a disease, I will have a symptom. Okay. Now, that symptom is due to the disease. I can take a management, I can take a treatment. Okay. And that experience, frequency, duration, severity of the symptom, everything, the patient is perceiving it. We are not perceiving. Patient is perceiving it. Usually, we do ask this patient about the physical things only. Okay. So if a patient is having dyspnea, where is Niti? Her name was Nidhi, na? The second one who gave a case presentation here. Where is she? A kuti illa. But a case present the second time, who was that? No, she was the first one who gave that. രണ്ടാമത്തെ പ്രാവശ്യം ആരാണ് കൊടുത്തിരുന്ന കേസ് പ്രസന്റ് ചെയ്തത്? You are. Sit. Okay, so my question will be to the patient is, when you feel breathless while walking or while climbing, അത് ചോദിക്കേണ്ട ആവശ്യമുണ്ട് അല്ലേ? I'm walking in this plain place, I'm not distressed. But when I walk 2-3 steps, climb the steps, I feel distressed. Where I have to tell the patient, you have to avoid climbing the steps. Okay. So, when we talk to that patient, we need to find out also whether it is mild, moderate or severe. Okay. Now the second thing is, when you feel this breathless, what happens? You will have anxiety about it. Normally what happens, it is a cycle another. Okay. I become anxious, breathlessness will increase. From breathlessness, again anxiety. So it goes on like this. Okay. So why you are anxious? That is the next question. Because the patient need to tell why as I told you, patient feel that I will die. Because my breathlessness is increasing means, my disease has progressed. So that thought comes, again the patient's breathlessness will increase. Okay. So we need to ask the patient exactly why the patient is having this breathlessness, what makes the patient anxious. അതല്ലെങ്കിൽ whatever medications you are giving, അതിങ്ങനെ കൊടുത്തുകൊണ്ടേ ഇരിക്കേണ്ടി വരും നമ്മൾ. So our root ആണ് നമ്മൾ പിടിക്കേണ്ടത്. So that is why we say, treat the patient as a whole. It's not on physical, psychological, social, എന്തുണ്ടെന്നും കൂടി നമ്മൾ നോക്കണം. We went and met a patient in the home visit. Abdullah was not talking to us. He just turned to one side and he said, I don't want to see anyone. We asked the family. Family said, not eating, not taking medications since past 1 week. Very adamant. So we asked, why? പുറത്തേക്ക് പോകണമെന്ന്. I have been in this bed last 1 year. എന്നെ പുറത്തേക്ക് കൊണ്ടുപോകാൻ പറഞ്ഞപ്പോൾ ഇവർ കൊണ്ടുപോകുന്നില്ല. So the answer from the family was, മൂത്രത്തിന് ട്യൂബ് ഇട്ടിരിക്കുക. ഇങ്ങനെയാണ് അവർ പറഞ്ഞത്. മൂത്രത്തിന് ട്യൂബ് ഇട്ടിരിക്കുക, എങ്ങനെ പുറത്തേക്ക് കൊണ്ടുപോവുക? So our team, we had a discussion and we told, we need to talk to your son. Magan vannu. We told him, take your upa outside. അയാൾ വന്നിട്ട് മീൻ വിൽക്കുന്ന ആളായിരുന്നു. Past 40-50 years in one corner of one place, he was selling fish. And his only this one was, just take me out. I want to be out of this place. Socialization illa. He's not seeing anyone. He's not talking to anyone past 1 year. So finally, son was convinced. He said, okay, I will take you. Okay, after 1 week, they called us and they said, ഉപ്പ മരിച്ചു എന്ന് പറഞ്ഞു. പക്ഷേ വിത്ത് ദാറ്റ് ഹി ആഡഡ് സംതിങ് വിത്ത് ദാറ്റ്. സേ അന്ന് നിങ്ങൾ വന്ന് പറഞ്ഞില്ലായിരുന്നെങ്കിൽ ഉപ്പേനെ പുറത്തേക്ക് കൊണ്ടുപോകില്ലായിരുന്നു. പക്ഷെ അത് വലിയൊരു നഷ്ടമായി പോയേനെ. കാരണം ദാറ്റ് ഡേ അവർ പുറത്ത് കൊണ്ടുപോയി അത്ര. ദേ ഹാവ് ടേക്കൺ ഹിം ഔട്ട്. എവിടെയാണ് ഇയാൾ ഫിഷ് സെല്ല് ചെയ്തിട്ടുണ്ടിരുന്നത് ആ സ്ഥലത്ത് പോയിരുന്നു. ഇപ്പോൾ പുതിയ ആൾക്കാരൊക്കെ വന്നിട്ടുണ്ട് അവിടെ. പക്ഷെ വാട്ട് ഹീ നോട്ടീസ്ഡ് വാസ് എനി പേഴ്സൺ കമ്മിങ് ടു ബൈ ദ ഫിഷ്, അബ്ദുള്ളനെ അറിയുന്ന ആൾക്കാർ ദേ യൂസ് ടു പാസ് ആൻഡ് ഗോ ആൻഡ് ടോക്ക് ടു അബ്ദുള്ള. അബ്ദുള്ള കുറേ ആയില്ല നിങ്ങളെ കണ്ടിട്ട്, എവിടെയായിരുന്നു? സോ ദാറ്റ് whole evening he spent, he was talking to all the people, and the son noticed, he was so happy, it seemed. He came back home, he had his medications, he had taken food. That 1 week, he was very happy. After 1 week, he passed away. See, in symptom occurrence, this happens, but that distress, I'm talking about the distress, okay? That is it. So I told you, I am having breathlessness. I want to take my grandchild, but doctor told me, if you lift something, you will have breathlessness. But now my problem is not the breathlessness. What is my problem now? I want to lift my grandchild. So that is the distress. That is the impact of the symptom on our life and our family's life. And this is important than their disease. So symptoms are not well controlled due to poor assessment. വയസ്സായ ആൾക്കാർ, ജീരിയാട്രിക് ആൾക്കാർ യൂഷ്വലി, ഇൻക്ലൂഡിങ് മീ, ഐ എം ടെല്ലിങ്, ഓക്കെ, ഞാനിപ്പോൾ ആരെങ്കിലോട് ഐ എം ഹാവിങ് ബാക്ക് കേക്ക് എന്ന് പറഞ്ഞാൽ ആദ്യം പറയുന്നത് എന്താണെന്നറിയോ? ഓ, ആർമിയിലല്ലേ ജോലി ചെയ്തിട്ടുണ്ടായിരുന്നു, സോ ആർമി ഈസ് വെരി സ്ട്രിക്റ്റ്, വി ഹാവ് ടു ഓൾവേസ് സ്റ്റാൻഡ്, we cannot sit and all. Lovely miss avada poi. Okay, we have to stand. Most of our timing is mostly standing. Okay, we cannot sit for. Okay, so and lifting the patients, no bystanders and all, we have to do everything. So അവർ പറയണത് എന്താ വെച്ചാൽ അങ്ങനത്തെയൊക്കെ ജോലി ചെയ്തുകൊണ്ടാണ് ബാക്ക് പെയിൻ ഉള്ളത് എന്ന്. വയസ്സായ വീട്ടിലെ ആൾക്കാരുണ്ടെങ്കിൽ മുട്ടുവേദന എന്ന് പറഞ്ഞാൽ എന്താ പറയുക? വയസ്സായതല്ല, മുട്ടുവേദന ഉണ്ടാവുമെന്ന് അതല്ലേ പറയാം സാധാരണ, അല്ലേ? ശ്വാസം മുട്ടലുള്ള ഒരാളോട് എന്താ പറയുക? ആസ്തമയല്ല, തണുപ്പല്ലേ, അതുകൊണ്ടാണ് ശ്വാസം മുട്ടൽ ഉണ്ടായത്. കറക്റ്റ് അല്ലേ? ബട്ട് എനി ടൈം ദാറ്റ് സിംറ്റം ഹൗ ഇറ്റ് ഇമ്പാക്ട്സ് മീ നമ്മൾ അന്വേഷിച്ചിട്ടുണ്ടോ? എനിക്ക് ആരുടെയും സഹായം അല്ലാതെ ഐ വോണ്ട് ടു ഗോ ടു ദ വാഷ്റൂം, ഐ വോണ്ട് ടു ടേക്ക് കെയർ ഓഫ് മൈ സെൽഫ്, ബട്ട് ഐ ഹാവ് ടു ബി ഡിപ്പെൻഡ് ഓൺ someone. That gives me distress. When I am having an indwelling catheter and I am taking and walking in front of others, it will pain me. It hurts really. Even if it is in my house also, it hurts. So, impact of that symptom is very, very important in one's life. And of course, in the patient, family's life also. So, health professionals has to be trained the skills of communication and assessment. So it has again 2 parts. I'll be talking about that. We are coming to that. I just put pain assessment. This you can use for any symptoms accordingly. Kada avada endha ezhudirikkana, you can read. See, OPQRST and UNV. We will come to that. When you are asking about symptom, onset is very important. When it started, എപ്പോഴാണത് തുടങ്ങിയത്, അതിന് മുന്നേ എങ്ങനെ ഉണ്ടായിരുന്നു? സോ ഇഫ് യു ആർ ആസ്കിങ് മീ എപ്പോഴാണ് കോൾഡ് തുടങ്ങിയത്, 2 days ആയി, അതിന് മുന്നോ നത്തിങ് വാസ് ദർ. സോ സംതിങ് ട്രിഗർ ഹാസ് ഹാപ്പൻഡ് ദാറ്റ് ഐ സ്റ്റാർട്ടഡ് ഹാവിങ് എ കോൾഡ്. ഓക്കെ, സിമ്പിൾ തിങ്. വെൻ ഡിഡ് ഇറ്റ് ബിഗിൻ, ഹൗ ലോങ് ഡസ് ഇറ്റ് ആക്ട്, ആൻഡ് ഹൗ ഓഫൺ ഡസ് ഇറ്റ് ഒക്കർ? അതാണ് നമ്മൾ ചോദിച്ചത്. നൗ നെക്സ്റ്റ് പ്രൊവോക്കിംഗ് ആൻഡ് പാലിയേറ്റിംഗ്. പ്രൊവോക്കിംഗ് എന്താണ്? വെൻ ഐ സ്റ്റാർട്ട് വാക്കിംഗ് ഐ ഗെറ്റ് പെയിൻ. I am at rest, there is no pain. I walk, I'm breathless. I am at rest, no breathless. Okay, so that is P. Now Q. Q is the quality of the pain. What is quality of pain? What is quality of pain? Anyone? What is quality of pain? Correct. Good. See, quality of pain is throbbing, pinpricks. This is called quality of pain. പേഷ്യനോട് ചോദിക്കുമ്പോണ്ടല്ലോ ക്വാളിറ്റി ഓഫ് പെയിൻ എന്ന് വെച്ചാൽ പേഷ്യൻ പറയില്ല. പേഷ്യനോട് എടുത്ത് ചോദിക്കണം. എങ്ങനെയാണ്? സൂചി കുത്തുന്ന പോലെയാണോ? ബേണിംഗ് സെൻസേഷൻ, അത് നമ്മൾ പറയുന്നത് എന്താ പറയുക, എരിച്ചിലാണോ ഇല്ല പുകച്ചിലാണോ എന്നൊക്കെ ചോദിക്കുന്നില്ല. വി നീഡ് ടു ആസ്ക് ദം, ദെൻ ഓൺലി ദേ വിൽ കം ഔട്ട് വിത്ത് ദാറ്റ്. സോ ക്വാളിറ്റി ഓഫ് പെയിൻ ഈസ് വെരി ഇമ്പോർട്ടൻറ്റ്. വൈ യു നോ? There are different medications for different type of pain. Because we have nociceptive pain, we have neuropathic pain. Neuropathic pain is different medication and nociceptive pain is different medication. Okay, so if you don't ask the quality of pain, patient will get some medication where the pain won't be managed properly. Okay. Region and radiation. I'm having pain here. Is it radiating to somewhere? Our question should be next. അല്ലേ? ചിലർ പറയുന്നില്ല ചുമയ്ക്കുമ്പോൾ ഭയങ്കര വേദനയാണ് അവിടെ അല്ലേ? റീനൽ കോളിക്, പെയിൻ ഫ്രം ഹിയർ, ഇസ് ഇറ്റ് റേഡിയേറ്റിംഗ് ഇൻ ദ ഫ്രണ്ട്? ദാറ്റ് ഈസ് റീനൽ കോളിക് ആണ്. ബാക്ക് ഏക്ക് അല്ലേ? പെയിൻ സ്റ്റാർട്ട്സ് ഫ്രം ഹിയർ ആൻഡ് ഇറ്റ് ഈസ് റേഡിയേറ്റിംഗ് ടു ദ ലെഗ്. നൗ ദ ക്വസ്റ്റ്യൻ ഈസ് what type of pain you are having when the pain starts. I heard one patient told me, ഇവിടെ നിന്ന് കടച്ചിലാണ്, കേൾക്കണം കേട്ടോ, ഇവിടെ നിന്ന് കടച്ചിലാണ്, ഇവിടെ നിന്ന് അങ്ങോട്ടേക്ക് തരിപ്പ, പിന്നെ പുകച്ചിലൊന്ന്. 3 types of pain. See, it makes different. So we need to ask them how is that called. Okay. So radiating is very important from one part to the other part. Severity. How severe it is, you all know. 0 to 10, it is the numerical scale we can ask. Okay, 0 means nothing, 1 to 3 is mild, 4 to 6 is moderate, and from 7 to above it is severe pain. Ask the patient, how is your pain? I don't say that you have to look onto the scale. Scale joikkanilla, but you can ask the pain. Tolerable ano, alliyo? How is the pain with the medication and without the medication also? Okay, some patient they will tell, 3 days before when I came, the pain was severe. മരുന്ന് കഴിച്ചിട്ട് ആ സിവിയാരിറ്റി കുറഞ്ഞു, ഇറ്റ് ഹാസ്, ബട്ട് സ്റ്റിൽ ഐ ആം ഹാവിങ് പെയിൻ. കണ്ടിന്യൂ പെയിൻ ഈസ് ദർ, ബട്ട് ദറ്റ് സിവിയാരിറ്റി ഹാസ് reduced. That doesn't mean that he has to stop the medication. He has to continue with the medication. Why? With the medication, the pain has reduced. He cannot stop it, especially in cancer patients and all. It's very important. Now, treatment. What medication the patient was taking, now what he is taking, and how he is taking. Patient was given morphine. 3 days back, 3 days after he came, and he said, my pain has not reduced. And you know, first day he took the medication, pain did not reduce, so he stopped the medication. I said, nothing can be done with that. Because we have told the patients, if you are taking 4th hourly this medication, in between you are getting a pain, you need to take extra dose. And come and tell us how much extra dose you have taken. Maybe our dosage was not proper, right? Otherwise, maybe with this he is having some other problem, and that is called psychological, social and spiritual problem. Now you know, physical problems always on the upper hand. Why you know? Because we don't address the other concepts of total care. Patient came with backache, simple, flat, തിരിയാൻ പറ്റില്ല എന്നൊക്കെ പറഞ്ഞു. ഒരു 30 years old ലേഡിയാണ്. ഓക്കെ, so she was little reluctant to talk to me in front of her mother-in-law. Okay, so usually how we talk in palliative care is പേഷ്യൻറ്റും പേഷ്യൻ്റെ ഫാമിലിയായിട്ട് സംസാരിക്കും, പിന്നെ മാറ്റിയിട്ടും സംസാരിക്കും, because there may be some things they want to tell us. So I asked her, അമ്മ ഒന്ന് പുറത്തു പോയി ഇരിക്കുക, ഒന്ന് ഇവരോടൊന്ന് സംസാരിക്കട്ടെ പറഞ്ഞു. ഓക്കെ, she went. Then I asked her, okay, എന്താണ് പ്രോബ്ലം? അപ്പോൾ യൂഷ്വലി ഇൻ പാലിയേറ്റീവ് കെയർ വി ഗെറ്റ് പേഷ്യൻസ് വിത്ത് ലോ ബാക്ക് ഏക്ക് ഓൾസോ. Okay, because we can give them some epidural and all. Okay, so what she told me was, വേദന ഉണ്ട്, പക്ഷെ അത്രയ്ക്ക് വേദന ഇല്ല. അപ്പം ഞാൻ പറഞ്ഞു, അനങ്ങാൻ വയ്യാന്നാണല്ലോ പറഞ്ഞത്, പറയാം അതൊക്കെ പറ്റും. ഞാൻ വീട്ടിലത്തെ പണിയെടുത്ത് മടുത്തുന്ന്. അതാണ് നെക്സ്റ്റ് വന്നത്. രാത്രി 11 മണിയായാൽ ഇവരൊക്കെ കഴിക്കുക എത്ര മണിക്കാണെന്നറിയോ എൻ്റെ സിസ്റ്ററെ? ഇവരൊക്കെ കഴിക്കുക 10 12 മണിക്കാണ്. ഇവരെല്ലാം കഴിച്ചിട്ട് വേണം എനിക്കിത് മുഴുവൻ കഴുകി വെക്കാൻ. രാവിലെ എഴുന്നേറ്റ് കുട്ടികൾ സ്കൂളിൽ പോകുമ്പോൾ ഭക്ഷണവും ഉണ്ടാക്കണം. എനിക്ക് റെസ്റ്റ് ഇല്ല. നോമ്പ് വന്നു കഴിഞ്ഞാൽ 3 മണിക്ക് എഴുന്നേറ്റേ ഉണ്ടാക്കണം. ഒരാൾ എന്നെ സഹായിക്കില്ല. ഉരവേദന ഉണ്ടില്ലെന്നല്ല, പക്ഷേ പറ്റുന്നില്ല. ഞാൻ വിചാരിച്ചു ഒരാഴ്ച ഇവിടെ വന്ന് കിടക്കാമെന്ന്. That was the psychological problem for her. And then I talked to their mother-in-law. Mother-in-law ഞാൻ സംസാരിച്ചു. ഞാൻ പറഞ്ഞു she is having a low backache. അത് guaranteed ആണ്. But അത് കൂടുതലാവുന്നത് നിങ്ങളെല്ലാവരും കാരണമാണ്. That time only she also realized that this lady is sleeping at night to 1 o'clock ഒക്കെ. എഴുന്നേൽക്കുന്നത് 4 മണിയാകുമ്പോഴേക്ക് എണീക്കണം നെക്സ്റ്റ് ഫുഡ് ഉണ്ടാക്കാൻ. Can you imagine what it is? കോവിഡ് ടൈമിൽ ഐ തിങ്ക് യു ഓൾ വർ ഇൻ ദ സ്കൂൾ റൈറ്റ് അല്ലേ? ഓൾമോസ്റ്റ് അല്ലേ? അതന്നെ, നിങ്ങളൊക്കെ സ്കൂളിലായിരുന്നു കേട്ടോ. എനി ടൈം യു ഹാവ് സീൻ മെഡിക്കൽ കോളേജസ്. ഞങ്ങളുടെ മെഡിക്കൽ കോളേജിൽ ഞാൻ വർക്ക് ചെയ്യുമ്പം മോർണിംഗ് പോയിട്ട് ഞങ്ങൾക്ക് പഞ്ച് ചെയ്യണം. ഐ എം ഗിവിങ് യു എക്സാമ്പിൾസ് വൈ യു ഷുഡ് തിങ്ക് അബൌട്ട് ഇറ്റ്. പഞ്ച് ചെയ്യണം എങ്ങനെയാണ് അറിയാം? അപ്പോൾ ഇതിപ്പോൾ 2 സൈഡിലും വാർഡായിരിക്കും. ദിസ് ഇസ് വെറാൻഡ. പീപ്പിൾ ഓൾ വിൽ ബി ലൈയിങ് ഡൗൺ ഹിയർ ബിക്കോസ് മെഡിക്കൽ കോളേജിൽ അത്ര ബെഡില്ല. വിൽ ബി പായ ഇട്ടിട്ട് കിടക്കും. ബൈസ്റ്റാൻഡേഴ്സും ഉണ്ടാവും, പേഷ്യൻറ്റും ഉണ്ടാവും. ആരാ ബൈസ്റ്റാൻഡർ ആയ പേഷ്യൻ്റ് നമുക്കറിയാമില്ല. സോ പഞ്ചിങ് ചെയ്യുന്ന സമയത്ത് ഞങ്ങൾ എന്താക്കും, ഇങ്ങനെ പോയിട്ട് ചേട്ടാ കുറച്ചൊന്ന് മാറുമോ, എന്നിട്ട് പഞ്ച് ഇങ്ങനെയൊക്കെയാണ് ഞങ്ങൾ പഞ്ച് ചെയ്യുക. കാരണം എന്താ വെച്ചാൽ ചിലപ്പോൾ കാല് വെച്ച് ഇയാളുടെ മുകളിലായിരിക്കും ഞാൻ വെക്കുന്നത്. നിപ്പ, നിപ്പ സ്റ്റാർട്ടഡ് ഇൻ കാലിക്കറ്റ്. ഓക്കെ, വി വർ ദാറ്റ് ടൈം. ഫസ്റ്റ് ഡേ നിപ്പ വന്ന ഉടനെ മാസ്ക് ഇതൊക്കെ. ബസ്സിൽ പോകുമ്പോൾ ഡ്രൈവർ ചോദിച്ചു, അയ്യോ എന്തിനാ നിങ്ങൾ ജോലിക്ക് പോകണം? ഞാൻ പറഞ്ഞു ഞങ്ങൾ ജോലിക്ക് പോയില്ലെങ്കിൽ നിങ്ങൾ വന്നാൽ പിന്നെ ആരാ നോക്കുക? വി വർ സർപ്രൈസ്ഡ്. ഞങ്ങൾ കയറിയപ്പോൾ കോളേജിൽ ഒക്കെ ഫ്രീ ആയിട്ടാണ് കിടക്കുന്നത്. ഞാൻ പറഞ്ഞു കണ്ണടിച്ചിട്ട് നമുക്ക് പോകാൻ പറ്റുമോ? എങ്ങനെ വേണമെങ്കിലും പോവാം, ഇങ്ങനെയൊക്കെ പോവാം, ആരുമില്ല. സെക്കൻഡ് ഡേ തേർഡ് ഡേ ആകുമ്പോഴേക്ക് ഹോൾ കോളേജ് വാസ് എംപ്റ്റി. ആർക്കും അസുഖമില്ല, ഒന്നുമില്ല, ആരും വന്നില്ല ഹോസ്പിറ്റലിൽ. സെയിം തിങ് കോവിഡ് ഓൾസോ. എല്ലാവരും ഓടിപ്പോയി കളഞ്ഞു. അപ്പോൾ ആർക്കാ ആക്ച്വൽ അസുഖമുള്ളത്? തിങ്ക്. ആർക്കെങ്കിലും ഉണ്ടോ? വെരി വെരി ലെസ് പേഷ്യൻസ് ആർ ആക്ച്വൽ പ്രോബ്ലമാറ്റിക്. ബാക്കി എല്ലാവരും എങ്ങനെയാ അറിയോ? ലീവ് കിട്ടിയില്ല, ഒരു 10 ദിവസം വന്ന് കിടക്കുന്നു, വീട്ടിലെല്ലാം നോക്കണം, അങ്ങനെ വന്ന് കിടക്കുന്ന ഇഷ്ടം പോലെ ആൾക്കാരുണ്ടാവും. ബ്രെത്ത്ലെസ്നെസ്. പേഷ്യൻറ്റിന് ഡിസ്ചാർജ് പറഞ്ഞു കേട്ടോ. അപ്പം പേഷ്യൻറ്റിനോട് പറഞ്ഞു നാളെ നിങ്ങളുടെ ഡിസ്ചാർജ് ആണെന്ന് കേട്ടോ. നെക്സ്റ്റ് ഡേ രാവിലെ വന്നപ്പം നൈറ്റ് ഡ്യൂട്ടി സ്റ്റാഫ് പറഞ്ഞു പേഷ്യൻ്റ് രാത്രി മുഴുവൻ വലിക്കുകയായിരുന്നു എന്ന്. സാർ വന്ന് നോക്കിയിട്ട് പറഞ്ഞു ഓക്കെ വി വിൽ ക്യാൻസൽ ഹിസ് ഡിസ്ചാർജ്, ലെറ്റ് ഹിം ബി ഹിയർ എന്ന്. സാറ് പോയ അടുത്ത നിമിഷം എനിക്ക് കാണാം അയാൾ നല്ലോണം ഇതിൻ്റെ മുകളിൽ കയറി ഇരുന്നിട്ട് പാട്ടും പാടിക്കൊണ്ടിരിക്കുക. അപ്പം ഞാൻ പോയിട്ട് പറഞ്ഞു बाबा आपको तो डिस्चार्ज कल बोला तो आपको तो सांस का तकलीफ हो गया, अभी क्या हो गया? അപ്പം മെല്ലെ എന്നോട് പറയാ ഘർ ജാനൊക്കെ ബാധ, അതായത് വീട്ടിൽ പോയി കഴിഞ്ഞിട്ടുണ്ടെങ്കിൽ ഒരാൾ ഒരു ഗ്ലാസ് വെള്ളം പോലും ചോദിക്കൂലെന്ന്. ഇവിടെ കണ്ടോ ആപ്പിൾ കൊണ്ടുവരുന്നു, ഓറഞ്ച് കൊണ്ടുവരുന്നു, എന്നെ വന്ന് കാണുന്നു, കുറച്ച് ദിവസം ഇവിടെ തന്നെ കിടക്കട്ടെ എന്ന്. അത് ഈസ് ഇറ്റ് ഫിസിക്കൽ ഓർ സൈക്കോളജിക്കൽ? ദാറ്റ് ഈസ് സൈക്കോളജിക്കൽ. സോ നൗ യു അണ്ടർസ്റ്റുഡ് വൈ ഐ വാസ് ടോക്കിംഗ് ലൈക്ക് ദിസ്. ആക്ച്വൽ പേഷ്യൻറ്റിൻ്റെ ഡിസ്ട്രെസ് യൂഷ്വലി ഇറ്റ് ഈസ് മോർ ഓഫ് psychological and physical illa nalla, but when it becomes a chronic disease, psychological things, social and spiritual also tends into that, and the patient will show more of physical problems because we professionals, we don't address the patients or the families psychological, social and spiritual problems. Understanding an impact of that, adana ഞാൻ പറഞ്ഞു വന്നത്. Impact of that symptom on me and my family. Family says we cannot see him in pain, we cannot see him in crying because it hurts the family. അവരല്ല കാണുന്നത്. നിങ്ങളാന്ന് ആലോചിച്ച് ഇപ്പം നിങ്ങളുടെ ഡാഡി അല്ലെങ്കിൽ മമ്മി ആർക്കെങ്കിലും ഒന്ന് വയ്യാണ്ടേ ആവുമ്പോൾ വിഷമം വരില്ലേ? because we can see them suffering, so we also start feeling എന്തുകൊണ്ടാണ് ഇങ്ങനെ സംഭവിക്കുന്നതെന്ന്. whatever is there, നമ്മൾ പ്രൊഫഷണൽസ് ആയിരിക്കാം, anything. But one point when our own people are not well, we will start cursing even our professionals. That is the fact I am telling you. My brother-in-law is admitted now. Since past 3 weeks, they are not able to diagnose it. Even after diagnosis, they are telling still we want to confirm. Why you know? Because we all are in medical professionals. We all are medical professionals. So, അവർക്ക് പെട്ടെന്ന് ഒന്ന് സ്റ്റാർട്ട് അവർ പറയുക അക്യുറേറ്റായിട്ട് കറക്റ്റായിട്ട് കിട്ടിയാൽ മാത്രമേ നമ്മൾ മാനേജ്മെൻറ്റ് സ്റ്റാർട്ട് ചെയ്യുള്ളൂ എന്ന്. ക്യാൻ യു ഇമാജിൻ ദിസ് വൺ mental suffering he is undergoing? Whenever I go, he will ask me, Stella, what they are going to do now? What they are going to do? How many X-rays I have taken? How many CT, PET, എല്ലാം എടുത്തു കഴിഞ്ഞു. Done the biopsy. 3 people, 3 biopsy, they told something. Now what is correct? The mental thing, what we are undergoing now, that no one can understand. More than physical, he is suffering mentally with his family. And of course the value. The value means it is very important. I mean value of that symptom in my life and family life. Apart from that, നമ്മൾ ചെറുതായി കുറച്ച് വലുതാവും തോറും മീൻസ് ആസ് വി ഗ്രോ, വീട്ടിൽ പറയൂല്ലേ വീട്ടിൻ്റെ അകത്ത് മൂത്രം ഒഴിക്കരുത്, തുപ്പരുത് പറയാറില്ലേ അച്ഛനമ്മമാർ നമുക്ക് പഠിപ്പിച്ചു കൊടുക്കുന്ന കാര്യങ്ങളല്ലേ. വീട്ടിൽ തുപ്പരുത്, എന്തെങ്കിലും ചെയ്തു കഴിഞ്ഞാൽ കൈ കഴുകണം. ഓക്കെ, ഇപ്പം വൺ ചൈൽഡ് കെയിം ഫ്രം കാനഡ. അപ്പോൾ ഇങ്ങനെ ചുമച്ചു, അത് വേഗം ആൻറ്റി യു ആർ നോട്ട് സപ്പോസ് ടു ഡു ലൈക്ക് ദാറ്റ്, എൽബോ എന്ന്. ഞാൻ കുറച്ച് നേരം ആ കുട്ടീനൊന്ന് നോക്കി, ആകെ കൂടി ഉള്ളത് 2 വയസ്സാണ്. അതെന്നെ പഠിപ്പിച്ചതാണ് ഇവിടെ വെച്ചിട്ട് ചുമയ്ക്കണമെന്ന്, കാരണം അവിടെ പഠിപ്പിച്ചു കൊടുക്കുന്ന സ്കൂളിൽ. ഓക്കെ, സോ values are very important in our life. But at times what happens, when that value we are not following, that hurts the patient also. I'll give an example of that. Jharkhandil patients in home care കാണാൻ പോയപ്പം one patient started crying. Patient has a very bad wound on the face also. So patient rice tube ഒക്കെ ഇട്ടിട്ടുണ്ട്, a lot of secretion. So he used to spit in the sputum mug. Okay, അപ്പം ഒരു 3 വയസ്സുള്ള മോനാണ് അത്ര. He came just running into the room. So as a father he called him, बच्चे आ जाओ करके. So what the child did, he stepped back and he said to him, आपको देखने में अच्छा नहीं लग रहा, गंदा सा है ना, you are looking very ugly. Smell ഉണ്ടായിരുന്നു woundന്. Then after that he commented it same. What he commented, you know, पापा आपने तो बोला घर के अंदर थूकना नहीं है, आप तो अभी घर के अंदर ही थूक रहे हैं. See, അയാൾക്ക് അത്ര വേദനിച്ചിട്ടുണ്ടാവില്ലേ, കാരണം അയാൾ പഠിപ്പിച്ചതാണ് വീട്ടിൽ തുപ്പരുത് എന്ന്. ഇപ്പം അച്ഛനോട് ആ കുട്ടി പറയുന്നത് എന്താ, ഞങ്ങളിങ്ങനെ പഠിപ്പിച്ചു, നീ തന്നെ എന്താ ചെയ്യുന്നത്, തുപ്പുന്നത്. സം വാല്യൂസ് ദർ ആർ ദർ ഇൻ ലൈഫ്. ചിലപ്പം ഹിന്ദു ഫാമിലീസ്, ലൈക്ക് മോസ്റ്റ് ഓഫ് ദ ക്രിസ്ത്യൻ ഹിന്ദു ഫാമിലീസും കൊണ്ട് വൈകുന്നേരം 6 മണി കഴിഞ്ഞാൽ വിളക്ക് കത്തിക്കണം എന്നൊക്കെ അല്ലേ, പ്രാർത്ഥന അങ്ങനത്തെ. ചിലപ്പോൾ ദ എൽഡർലി പീപ്പിൾ ദേ ഫീൽ ബാഡ് വെൻ വി ആർ നോട്ട് ഡൂയിങ് ദാറ്റ്. So lot of values are there which the family feels, always patient feel, makes my symptom more worse. Okay, so that is why we say don't talk only about physical, try to talk to the patient on psychological, social and spiritual problems of the patient, so that the patient will open up to you and tell his problems. And that is called as a whole person. And that is the concept of total care. Okay? Thank you all so much. Dr. Thambi vannittund class edukane. Okay? I hope you understand something.
That was indeed a wonderful session. Thank you, ma'am.
As we move forward with a significant session by an eminent person who needs no introduction, none other than our beloved Dr. P.T. Thambi, Senior Consultant Anesthesiologist and Palliative Care Physician from Pushpagiri Medical College Hospital, with a huge round of applause for the session on Advanced Pain Management, Relief and Comfort Care, Quality of Life.
Good morning to all. First of all, let me thank the organizing committee for giving me this opportunity to present this topic today. I also appreciate the College of Nursing authorities for selecting this palliative care for a full 2 days CME. Understanding the importance of this palliative care. It is the need of the hour, palliative care, because in the last, say, 35 years, Kerala has become the first state to have a coverage of palliative care in almost all the villages in Kerala. There are many states where they have not heard of palliative care. So we have achieved a lot. But the problem is still we are not able to give palliative care to 50% of the patients who are really in need. So we have to go a lot in the future years. See, symptoms are common in end-stage diseases, whether it is cancer or non-cancer. And most dying patients, they need the relief from their symptoms. The saddest part of it is, once they are labeled as terminally ill, they are given up, saying that we have nothing more to do for you. And here we understand the situation and we take care of the patients, offering and assuring them that we will relieve you from your suffering. Coming to pain. The meaning of pain in advanced cancer is, I am incurable. The patient is feeling, I am incurable. So I am going to die. This is what we call total pain overall. We have a WHO definition of pain. Pain is an unpleasant sensory, emotional experience caused by trauma, actual or potential tissue damage. That is the definition of pain. Pain is what the patient says it hurts and not what others think it ought to be. Because, as I have mentioned, pain is an emotional experience. One person having an illness, he may not have pain. He might not have had pain, but the same condition, another patient may be having worst pain. So it is for the patient to decide what they have. And it's not the caring person to decide, no, I have seen many patients. The pain is different. He didn't have that pain. How can you have? So it is all what they have. Pain is multidimensional. It is, we think in terms of total pain and total suffering. It has got 4 aspects: pain and suffering, psychological, social, spiritual, and the last but the most important is physical. So all these 4 contribute to the total pain. So what is meant by that? As you see, physical pain, as we understand, it's all affecting the physique. They may have associated symptoms. It may be localized. It may be due to the treatment itself. But psychological pain, the patient present in many ways. They may consider, they may suffer the pain. They may have a feeling that it is due to delay in the diagnosis, failure of the treatment, fear of disfigurement, or fear of death. Social pain is different. All these patients, they may have family problems, financial problems. They may be worried about the loss of their position in this family and the society. They may be having a feeling of abandonment. It is very common to see that in many of the families, when one member of the family is affected by such a major illness. I had seen many families where the partner has left the person and he was left alone, leaving all the burden of the family to this affected person. Fourthly is the spiritual aspect of it. They all have a feeling that, why should I get this problem? All my friends who was with us, they are all safe, very healthy. But why? Why to me? Why God is allowing me to suffer all this? What is the meaning of living like this in this world? And another thing is, many feel that it is a punishment to me. So all the 4 components make up the total pain. So while treating the pain, we have to consider all this. When the physical pain is treated, the patient may not be all right. They may be having insomnia, they have a loss of appetite, all these problems. I had a very good example a few years back. One lady was admitted in our ward with severe pain. She was alone. Her husband died a few years back. And she came and admitted with severe pain. She had a liver problem. And after 1 or 2 days, physical pain was relieved. I thought she will be all right. But she said, I am not able to sleep. I can't even close my eyes. So when I probed into the depths, I found that the cause of her pain was, she had a son, only son, He was admitted in an engineering college when she was healthy. And they have given the first installment of fees, and after that they could not pay the fees. So she was afraid he will he won't be able to complete his education. So she told me this, and the same day our society authorities met and discussed the issue. And we found that the boy was admitted in Kanjirapalli, one of the engineering colleges there. And we decided to support this boy for the education. And we told her to call the boy. Next day he was present, he came. We called them, we discussed everything, and we promised her that he will be able to continue his studies there. So onwards, we paid all the fees, the remaining 4 years. He completed his BTech, and happily he is employed in one of the Gulf countries now. What happened to her? Once this promise was given, she was completely relieved of her pain. She started sleeping, she started taking food, but in 1 week's time, she left this world. So that is why I wanted to say that when we talk of pain, it is not the one component alone that is important. Pain can be classified into different types of pain. There are different classifications. So I just simplify this. Acute pain, chronic pain, cancer pain, nociceptive pain. Physical pain itself is somatic pain, visceral pain, neuropathic pain. So all these different terminologies are there. I am not going to the details of it. Just to mention that acute and chronic pain, they have different physical signs and psychological associations and require different approaches in treatment. Acute pain is due to a definite injury or illness. It has a definite onset and duration, and it has a predictable limit. The acute pain is accompanied by anxiety and the clinical signs of sympathetic overactivity like tachycardia, tachyapnea, sweating, etc. Whereas in chronic pain, this may not be present because they are suffering from this pain since long. And the chronic pain results from a pathological process, and it has gradual onset, continuous, unabated, and become progressively severe. The patients, they may be depressed because they finally feel that this pain is not going to be relieved. They have to suffer from this. And so they don't look like having a pain. But patients who have got cancer pain, they not only lack any positive sign, but they have definite negative implications. They have a negative feeling about their life expectancy, and these people have to be distinguished from those patients with non-malignant pain because the treatment is different. So here we have to assess this pain. Some terms associated with pain: breakthrough pain, incidental pain, and neuralgia. These are all different terminologies associated with pain, just for your information. So when somebody comes with pain, we have to evaluate the pain. site of the pain. There is a short form, Socrates, S-O-C-R-A-T-A-S, Socrates. Site, the onset, characteristics of the pain, radiation, associated symptoms, timing, aggravating factors, and severity. So all this has to be taken into consideration because for treatment, all these are important. You classify that particular pain from the clinical details you get from the taking of history. So acute pain I have already mentioned. It has got definite onset and duration. Chronic pain, yes. Cancer pain. Cancer pain is due to cancer itself, or it is due to the treatment of the cancer, maybe surgery, radiation, or even chemotherapy. So, due to the treatment. And this pain, they have negative implications regarding the prognosis and life expectancy. And they have to be distinguished from non-cancer pains before treatment. These patients fail to respond to care or analgesia, normal drugs. So, before we start the treatment, we have to measure the pain or quantify the pain. We have simple tools for measuring pain. Visual analog scale. It is simply drawing a line. At one end there is no pain, the other end very bad pain. You can ask the patient, you put a mark wherever you have pain. This is visual analog scale. Numeric scale. Numeric scale is 0 to 10. You can ask the patient how much is your pain. And the third one is verbal scale. They can say no pain, mild pain, moderate pain, severe and excruciating. So you get the details from the patient. How? That is the part of the communication. The communication has to be very important because it is very important to discuss with the patient about the different types of pain, assessment, and the types of pain. It will provide the information about the cause of pain and indicate which therapeutic modalities are appropriate. The patient's description of the type of pain and its severity must be accepted as true. It is necessary if there is to be trust in the patient and the caretaker's relationship. The patient should be asked to describe their pain in their own words, in their own way. The language, the facial expression, the body language, their emotions all provide considerable information about the pain. We must know what drug they have been using in the past for pain, at what dose, and if they had any side effects. All these details has to be extracted from the patient. Good communication is essential for good pain control. We have to listen carefully to the patient and his description. See, just listening. What is happening nowadays is we don't get time to listen to the patients. We say listening is the most important thing in pain management or palliative care. We also have to, I feel regret sometimes, because after the COVID pandemic, we try to keep away from the patient. How many of us touch our patients? How many of us touch the patient without a gloved hand? A touch with a gloved hand and a touch without a glove makes a lot of difference. In the protocol, nursing protocol, I think it is a must to wear gloves. So that is why I said after the COVID pandemic, all these problems have kept us from giving proper care. And to be frank, I never use gloves in my ward, except for doing procedures, tapping or things like that. I still touch the patient with my bare hand, because I feel that it makes a lot of difference. Touch. A touch from the caring team gives a lot of comfort to the patient. A very good communication with the members of the treatment team will ensure a coordinated approach for pain control. Many patients believe cancer is inevitably associated with severe pain and that pain is unrelievable. They should be assured that the pain can be alleviated immediately, and a positive approach is to be encouraged. Acceptance of pain should be discouraged. We can assure them that pain can be relieved completely. We have wonderful drugs now. So we can confidently assure them your pain can be relieved. Reassurance. We can reassure them. You can live comfortably without. That is the purpose of pain management. In the always we say improving quality of life. Pain control is one of the important things in improving the quality of life. So once you reassure them, you can expect them to participate in our all measures to relieve their symptoms. No place for the use of placebos in the treatment of cancer pain. It is unethical and it will lead to distrust if the patient, our patients are intelligent patients. Once you give some drugs, they know that is some vitamin tablets, and they will feel that this person was deceiving me, and he will never believe whatever assurance you give. So always be careful about this in the management of pain. Analgesics. General principles in the management of analgesics is always give adequate dose, titrate the dose for each individual patient. The dose for one patient may be higher for another person or lower. So for each patient, the dose has to be titrated. No PRN medications for analgesics in the treatment of cancer patients. And it has to be scheduled on a timetable. Give instructions for treatment of breakthrough pain. Breakthrough pain is, I mentioned first, it is a patient is on drugs and in between 2 doses, he gets a pain. That is what we call breakthrough pain. That also has to be treated. And that is, instructions are to be given to the nursing team. So, whenever possible, oral route is the best. And even though we have assessed fully, reassessment always makes a lot of difference. So, there is a protocol in the treatment of pain. We call it WHO ladder for pain management. It has got 3 steps. Step 1, step 2, and step 3. Which step you have to put the patient depends on your evaluation. First, we mentioned about the quantifying the pain. So, depending on that, you can decide which step the patient should come. If you decide to keep the patient on step 1, we give them NSAIDs and adjuvant drugs. Step 2, weak opioids and are added to the step 1, that is weak opioids plus NSAIDs plus adjuvants. And if it is on step 3, we add opioids, strong opioids to step 1, not step 2. So, the principle is don't combine 2 opioids. It is a guideline for treatment of pain. So, coming to the medication. I just try to stick on to the opioids because other drugs are you are all aware of it. We have different types of opioids: weak opioids, strong opioids, synthetic opioids, naturally occurring opioids. So, weak opioids are codeine and tramadol. Codeine is no more in use for treatment of pain because it is too weak and the side effects are too much. So, tramadol is a commonly used drug for mild to moderate pain. Tramadol will suffice. Coming to the strong opioids, morphine is a naturally occurring opioid. Others are synthetic, methadone, fentanyl, tapentadol. There are so many drugs. So, morphine, as I said, morphine is available in different forms: injectable forms, tablets, and liquids. Injectable forms, as I mentioned, in the treatment of cancer pain, we prefer oral route as far as possible. So, we have tablets with us. We have 10 milligram tablets and 20 milligram tablets. No standard dose for oral morphine. The titration is against pain. For each patient, the dose has to be titrated. And giving oral morphine, again I stress, it is given orally it is given by clock and it is given by ladder. These are the principles in the use of morphine. Morphine side effects are sedation, myoclonus, nausea, constipation, respiratory depression, and lastly, addiction. But most of the people, lay people, are afraid of addiction, which is the last to be considered. I have not seen a single person who developed addiction to morphine in my last 25 years of practice. I had a patient a lady who was taking 720 milligrams of morphine tablets in 24 hours. She was a thin lady, about 40 kg. She used to come by KSRTC bus from her home, reach our OPD, and she will take the 10 o'clock medicine sitting in our OPD. That is 20 milligram, 6 tablets. Nobody will believe that. And then he will get the medicines and go back in the next bus. So I think I am not telling the greatness in that, but I am telling it to say that morphine tablets in cancer pain will not produce addiction, provided the dose is titrated correctly. Because the side effects are very easily detectable for the patient. If a mild side effect is developed, they will come and complain to us. I have this problem. Is it due to this? So we can titrate the dose and see that the side effects are avoided. So addiction, that is why I wanted to say this. But sedation is common. Again, it can be by dose adjustment, we can do that. So coming to the details of oral morphine, tablets are given 4th hourly. So the duration of action is only 4 hours. We advise them to take the morphine tablets early morning, 6 o'clock, or when they get up in the morning, whatever time. Then 10 o'clock, 2 o'clock in the afternoon, 6 o'clock in the evening, and 10 o'clock when they go to bed, we give them double dose. Because 4 hourly it has to be given, and next 4th hour dose comes at 2 o'clock in the night. So a person who is sleeping nicely in good pain relief, if you wake him up and tell them to swallow these 4 tablets, their sleep is gone. So we give that midnight dose along the bedtime dose along with that. So when we write the dose, it is morphine, whatever milligram is there, 4th hourly, and double dose at bedtime. That is the dose we order in the sheet. So many people may misunderstand why this double dose at night. So the logic is only this simple: not to disturb the patient in the night. And if they sleep a little more, it makes them comfortable. So morphine is a wonder drug. Oral morphine is a wonder drug in the treatment of cancer pain. Hundreds or thousands of people have lived years pain-free with morphine without any side effects, irrespective of the age. So it is called a wonder drug. Only thing is, we have to be careful and we have to make sure that it is not misused. It's a scheduled drug. We have to use it carefully. So morphine when given orally, I'm not going into the pharmacology of the morphine because it is beyond the scope of this talk. But for better understanding, it is absorbed easily from the stomach, it is metabolized in the liver, and it is excreted through the kidneys. So there is if a patient who is being treated in nephrology, if they are referred to pain and palliative, they will advise them not to take any NSAIDs, not to take any opioids. So we find it difficult to convince them for pain. These are the drugs, but the dose has to be adjusted. So it's very difficult task to convince them that morphine does not worsen the kidney damage. Only thing is, because it is excreted through the kidneys, excretion will be delayed and it will have a cumulative effect. So in an ordinary person with active, both kidneys acting fully, the dose has to be reduced in the patients having kidney disease. Otherwise, it is very safe to use morphine in patients with kidney disease. And in liver disease also, the metabolism is delayed. So otherwise, it can be safely used. So once it is metabolized, it is acting on the central nervous system, and pain control is complete. We can achieve 90 to 100% of pain relief by oral morphine. Only thing is we have to follow the WHO ladder for the treatment. Morphine, though because it is a scheduled drug, there is a tendency among doctors to treat patients with other drugs. That is, they use tapentadol because it is easily available in the chemist shops. Only thing is the cost of it. It is a costly drug. Those who can afford, yes. But we don't use that because we have morphine. We have to consider the cost also. Morphine tablets, two types of tablets are available. Ordinary tablets, which has to be given 4th hourly, and slow release tablets are there, which can be given twice daily dose. So the duration of action is 12 hours. The cost is also different. So then another device for pain relief now very popularly used is transdermal patches. It is fentanyl transdermal patches. This also has to be used very carefully, but in our hospital, I see that these patches are, I have to say, I'm sorry, I have to say that it is misused. It is prescribed unnecessarily, even in post-operative pain relief or in other chronic pains. It is against our principle. We use only transdermal patches for patients who cannot take oral tablets due to the disease process in the esophagus or something, or they cannot tolerate it. Some patients develop severe nausea by taking morphine. And then we may have to go to other devices. We can use, in such situations, we can control the vomiting by antiemetics, heavy doses, and once this vomiting is only for 2 or 3 days, and once vomiting is settled, they can be administered oral morphine itself. Or due to some other causes, they can't swallow it, we have to use parenteral doses, subcutaneous or intravenous infusions or things like that. The only disadvantage of transdermal patches two types of patches are there. One is buprenorphine, another is fentanyl. Both are very costly. I said morphine tablets, 20 milligram tablets is only 5 rupees. So 6 doses of oral morphine is only 30 rupees. If the patient is relieved with 20 milligram tablets, the cost of the treatment is only 30 rupees. Whereas a fentanyl patch of equivalent strength costs about 900 rupees. It can be used for 72 hours. Why I say this is, in palliative medicine, we give a lot of importance to the financial aspect, because most of the patients, they are financially exhausted. When they come to us, they say, everything is gone, doctor. We have lost everything for the treatment. Now, you all know that the treatment cost is high, lakhs. They go for it because they were misled. They never are given the correct information, most of them. They are given false hope. If you take this injection, if they take this medicine, you will improve. And they spend everything. There are people who they have sold their houses and properties for the treatment, and finally they come, we lost the patient and we lost everything. They come and land up in palliative medicine. So we give a lot of importance to the financial aspect. So what I want to say is, this is important in the social issues. So I think I am little behind schedule. Can I take 5 more minutes? Yeah. So what are the expectations that can be given to the patient? Many cancer patients with long-standing pain, they have low expectations of pain relief. They have suffered enough and they say, this pain will remain with us till cemetery. So when first seen, all patients should be assured that the situation can be improved. It is possible to achieve at least some improvement within 48 hours. That is in very bad cases. Otherwise, you can say 100%, promise them pain can be relieved. However, with the pain exacerbated by activity, it is wise to aim at incremental relief. Initially, to forget a pain-free sleep, then comfort at rest during the day. The doctor and the other cancer carers must be determined to succeed, which is possible. We are prepared to spend the time evaluating and re-evaluating pain and other distressing symptoms. If this skill is not developed, the doctor and the patient become trapped because they never trust you anymore. Gaining the trust of the patient is very important in palliative care. Most of the right things will be done, but several days or weeks too late. Never say, there is nothing more I can do for you. Reassure that we can do something for you. That is the message we have to have with us. Anything, any questions? If there is. Yes. See, intravenous morphine is very safe. Only thing is, how many doses of intravenous morphine can be given? Because the most important side effect of morphine intravenous is respiratory depression. So you give 1 dose. 1 dose enough to produce or develop addiction, dependence. Okay, forget about dependence because the patient is too bad. So the next problem is the patient wants to go home. You have relieved the pain by giving a single dose of morphine. Patient is happy, 100% pain relief. How will you send him home? Patient cannot have morphine at home. You cannot prescribe it to be given. So you have to have an oral alternative. So that is why I said in patients who are admitted in the hospital on a permanent schedule, who cannot take tablets, either because of the disease or due to the side effects. He cannot have oral medications. Then you can think of injectable morphine, but the problem is you have to continue with that only. The other alternative is transdermal patch, if the patient can afford. That is a very important factor, affordability. Am I clear? Yeah. So, no more questions? Thank you. Once again, thanks to the organizing committee for giving me this opportunity.
A heartfelt thank you for sharing your expertise. Now, I request Vinitha ma'am to present the memento to Dr. P.T. Thambi for his valuable presence and contributions.
Thank you, ma'am. Thank you, sir. Up next, we have a session on innovation in palliative care, a new frontier which will be handled by Lieutenant Colonel Lovely Anthony. Let's welcome Madam with a huge round of applause.
Good afternoon. Sorry. So, how are you all? Tired of sitting? Want to just get up and stretch? If you want, you can. Just get up, stretch yourself, and then sit back. Because afternoons are always tiring, isn't it? Like, so just get up, stretch yourself, and then you can sit down. Okay. So, actually the world in which we are living is not what we were born, isn't it? There are changes taking place in every sphere around us. Same ways innovations also. So what we have learned or seen today may not be adequate to meet the challenging demands of tomorrow. So, since science and technology is fast advancing, and also there are a lot of innovations taking place. So, we need to incorporate innovations in our professional life, especially in palliative care. Many a times we may think why it is needed, but we need to incorporate innovations in our palliative care practice also. So, innovation in palliative care is not machines replacing humans, but technology amplifying the care only which humans can give. So, it is not, we must always remember that the technology can never replace. Like morning Stella was telling, the art is gone. But in palliative care, the art or the hand needs to be in constant work to provide proper care to the patient. So, innovation is actually seeing what everybody has seen and thinking what nobody has thought. So, where we can incorporate innovation, that is what we should be able to adapt as per the needs of the patient. So, why innovation is needed in palliative care? So, we will see, because our population is, we have already discussed, our population is rapidly aging, and the chronic conditions like many heart diseases, cancer, kidney problems are increasing, and also we have a shortage of trained staff, isn't it? Because of there's a lot of migration taking place. So, because of that, the patients, Stella was telling about 98% of the patients, even in India, is not receiving palliative care, what they should have received. So, because of that, maybe we need to use innovative techniques to provide timely support to our patients. Now, again, like when we think of urban-rural divide, like we have got a lot of facilities in urban area, whereas in rural area it is lacking. So, because in urban area, like we say actually when we think of urban-rural divide, we say actually about 75% of the population of India is living in rural area, whereas 75% of our healthcare facilities are located in the urban area. So, because of that, there is the true urban-rural divide, which affects the caregiver of the patient. It means the patient who really need it is not able to receive it, or we are not able to provide the care needed to those patients who are requiring them. So, because of this, innovation is essential to address the gap and to provide timely needed care to these patients. Now, so looking at the innovation technologies in palliative care, I will be concentrating on basically three aspects. One is emerging technologies in palliative care, artificial intelligence, and telehealth. So, we will see them one by one. So, in emerging technologies in palliative care, because many times these days you will see actually palliative care has become, many people are preferring palliative care especially at home, because they don't want to lie down in an ICU surrounded by ventilator and so many tubes. They love to be with their loved ones in their own home in the familiar situations. So, there they feel the quality of life as per them is being at home and getting attention from somebody dear and near to them. So, like in the emerging technologies we have wearable devices, digital health records, virtual reality and augmented realities, and mobile applications. So we'll just discuss them in very brief. Now you might have seen, many of you must be using smartwatches, isn't it? Where you are, at least some of you must be having it. So where you can record your heart rate, where you can, so maybe you are able to monitor them. So same thing can be utilized by the patients also who can afford it. Now again, affordability is a problem here, but these days even there is a lot of like corporate social responsibility. Now as part of CSR, that is corporate social responsibility, there is a lot of sponsoring coming. So because Government of India has made a rule that as per CSR, about 20% of the money has to be sent for corporate social responsibility. So because of that, we do get some amount of sponsorship and funds. So when it is available, when we can afford, we should utilize them. So here, these wearable devices like maybe smartwatches can be utilized to monitor the vital signs, maybe heart rate, and also for giving alert to the caregivers. Like sometimes, no, because many a times you will see actually when you see, you will go visit the house, you will see only like the patient and the spouse is there. Both of them may be elderly. Now spouse also need to take some rest, isn't it? So if there is some problem, if something is there, like which there is alert is given to them. So that type of devices can be utilized. Then electronic health records. Now electronic health records we are often using in the hospitals, but it can also be used in the home care situation. Like again I told, if it depends on actually affordability, but it is being used in some places even in Kerala. Next is augmented reality. Augmented reality and virtual reality. This is basically to boost the morale of the patient, to change the, like many a times you will see actually these patients are depressed, they are losing hope, so to cheer them up, to change their mood and to bring them, to ensure that they are not depressed. We are able to, like it is a sort of diversional therapy where we provide them a real world by using the technology which is available. Maybe we may use virtual objects, or maybe we may use actually smartphone, AR glasses, etc. can be used actually again. Now again here you told, like now in Calicut we have students in palliative care. Students in palliative care, it means many colleges have got palliative care units there. So they collect money and there they are providing to certain extent, especially in the pediatric wards, pediatric palliative care units, they are providing this type of experiences to them. And also like last year, NSS unit sponsored one child in Wayanad. The child's wish was to see the sea. The child wanted to visit the sea and enjoy and want to play in the seashore. So they collected the money and brought the child and allowed the child, took around the Calicut, and so those type of things also can be done. Now many a times when it is not, maybe they are giving a virtual reality to them to experience it with the help of technology. So in virtual reality, it uses immersive computer generated environment viewed through virtual reality headset to provide therapeutic benefits like maybe pain relief, anxiety reduction, and enhanced well-being by providing them, like now in our situation, like we normally tell them actually to show the childhood photos of the children, how they grow up and things like that. Like even our student volunteers, when they don't have anything else, so they tell them actually, when they go for sitting, no, like we have actually, we do, like when the caregivers, only one caregiver is there, taking care of the patient day and night. So the caregiver also needs some rest, isn't it? So many times you will see actually patient doesn't sleep in the night. Why? Because the patient feels, if I sleep, my wife will also sleep, and if something happens to me, nobody will come to know. So patient will not sleep in the night. If the patient is not able to sleep in the night, the caregiver is also not able to sleep in the night. So because the caregiver feels so tired, isn't it? So normally, like in the neighborhood network, sometimes even from SIPC, the volunteers go and provide them relief, like maybe 3 hours to provide and to ensure rest. So those times when these students go, what they do? They tell them actually, show that, let us see the album of your children. And then each photo they'll take out and ask, when did you take this photo? How was this thing, and things like that. And it's a diversional therapy for them. So exactly same way, same thing like these days with the help of artificial intelligence also, you are able to show those type of things actually to the children, just to divert their mind and to ensure that they are enhancing the well-being and mood elevation of the patient who is suffering from life-limiting illness. Now, when we think of augmented reality and virtual reality, actually augmented reality mixes digital elements with the physical world, while virtual reality replaces it with a fully digital one. This is the basic difference between AR and VR. So, now virtual reality is being used to help to reduce pain and anxiety, especially for patients in palliative or hospice care, offering a very unique or immersive experience for relaxation, or many a times even to fulfilling their wish list, as I was telling you. Next, another thing is immersive distraction therapy. It may be used actually to distract the patients from their physical pain that I was telling you about even while showing an album. And also emotional distress through calming virtual environment, because many a times when they are alone, they are thinking, why it has happened to me, why there is nobody to take care of me, what will happen to me tomorrow. I was telling you actually night they will think actually, if I sleep, my wife will also sleep, something happens to me, nobody will come to know. That is constantly worrying them. So those type of things, like because they have got nothing else to do, so basically as a volunteer or as a caregiver, or this thing is to distract their mind to something, some pleasant experience. Many a times maybe to exposure to a nature scenes or familiar places significantly reduce pain and anxiety levels. Now when coming to the therapeutic uses, another therapeutic use is flow VRT relaxation therapy, which based actually, it is again virtual reality based programs like Flourishing Life of Fish relaxation therapy. Now they normally have shown actually it significantly improves the condition of the patient. Many times we may also use virtual travel and memory reconnection, like sometimes they may say actually, yes, I was there and I was doing, I have this thing. So maybe you can show them actually, maybe like these days everybody is having smartphone, everybody is having chat GPT and things like that. You can ask them to show how that place is now and things like that. So there you are able to, basically I told you these things are being used to boost the morale, to distract their attention and to improve their mood. And basically relieve, because the main attention of pain is distracted to somewhere else. So it reduces their fatigue and also improves their overall well-being. Now many research is being conducted actually, and it is proved that actually these VR-based reminiscence do improve the well-being of the patient in palliative care. Basically, I was telling you actually, the patients can be taken for a meaningful visit to a place where he has lived or which he has visited or which he want to visit. Like maybe, these days many a times we have YouTube. So those type of things also can be shown to, like a patient, I remember telling, one of my students was telling, the patient wanted to see, visit Rome. That was the wish. They are not able, they had actually planned, but because of the illness he could not go. He wanted, his wish was to visit Vatican. So there actually, they have used this virtual reality and taken him for a ride, or where all those type of things where they were, means with the help of ChatGPT, those NIT students have shown those to the patients of one of our hospice. No, so actually, these life review and reminiscence therapy helps individuals, particularly the older adults and those with dementia, to make sense of their lives, strengthen their identity, and also it uses to reduce their isolation, improve mood and also cognitive functions and also communication. So, these various uses of virtual reality. Next is telepresence and human assistive robotics. Now, human assistive robotics, you might have seen actually a movie. Which movie was there? Which is used? Suraj Vanyaramud was there in a movie, with the robot. Which movie? Android? Yes. So, those type of things also. So, those type of things also can be used, isn't it? To help the patient. So, interconnected technologies allows users to feed the feeling of there is somebody to help them. It can be now, because if the people can afford, those type of things also can be used. So, this telepresence robotics provide a virtual presence, enabling remote interaction and social connections. Particularly, it is beneficial for people with mobility challenges in health, and can be also used to combat loneliness and improve access to care. So those of you who have seen the movie might have seen actually how that person has developed a rapport and affection to that robot, isn't it? So same thing can be, it is not, I'm not telling it can be used for permanently, but again to relieve the caregiver stress or burden. Those type of things can be utilized to certain extent. So, robotics is an emerging tool in palliative care, offering supportive roles to enhance the quality of life, autonomy and emotional well-being for the patients with serious life-limiting illness. While, I repeat, robots are not a replacement for human caregivers, but they can supplement care, especially where healthcare staff is limited, and especially also it can be utilized to relieve the caregiver burden, especially when no one else is, only one person. Like I was telling you, the students in palliative care do, but we do have our own limitations, isn't it? Maybe we are able to go and give care for maybe for 2 hours or 4 hours, but not more than that. But again, community, like when you also go for your community visit, when you see those patients, the community volunteers or community, those maybe you should be able to provide health education to those people who are at home, who is maybe retired but healthy, those type of people. Like in our area, we do have those type of network. Actually, when there is some bedridden patient, the caregiver needs a relief, somebody on rotation goes and spends some time, maybe 4 hours, maybe 3 hours. Sometimes they even cook the food and go and then eat, stay with the patient. The caregiver can be sent for rest, taking maybe 2 hours sleep, 3 hours sleep, and the caregiver sits there, maybe help them to, maybe sitting and talking to them, maybe allowing them, I was telling you, watching the albums, or maybe just being there to provide support to the caregiver. So there are social robots are also available which provide care to the patient. There are Paro, the robotic seal, Pepper, etc., which is utilized, especially in the foreign countries, to reduce feeling of loneliness and also anxiety. These robots can engage in simple conversations, play music, or mimic the pet therapy, which is particularly helpful for patients with dementia and also cognitive decline. Next, come to assistive robots can help with the mobility, or maybe robotic walkers, feeding, sometimes toileting, or help them to transform bed to wheelchair, etc. And it will enhance independence and dignity for patients who wish to remain home or reduce caregiver burden. And robots can also be used to deliver cognitive stimulation such as quizzes or memory games, and remind the patients about medications, when to take the medication, and also hydration, and also remind them about the appointments and things like that. So it can be like maybe incorporated in the system, and they can do those type of works. And they can also be utilized to maintain mental function and reduce the risk of depression and delirium, etc. Next is telepresent robots. They allow healthcare providers or family members to interact with the patients remotely. So it can be like many times I told, these days half of the patients' family members are abroad, so they can use this device for talking with the patient and interact with the patients from remote areas. And sensors and mobile robots can monitor the vital signs, medication adherence, and detect falls or emergencies also. And it can be used for, it can be helpful for them. And also for patients with speech and mobility issues, robots integrated with augmentative and alternative communication tools can facilitate communication with the caregivers and loved ones. So this can also be utilized for when they are being programmed for that purpose. Robots can also reduce caregiver burden by handling routine monitoring or physical assistive tasks, and may also offer respite care, giving human caregivers short breaks. I was telling actually, maybe to ensure that maybe like when they are sleeping, they can also give them, remind the caregivers when they are awake and things like that. Now we come to the limitation and ethical considerations in this. So there is emotional authenticity. Robots may stimulate empathy, but they do not feel it. So we cannot depend on them. So it should be always be on human supervision. Robots can never replace a human being, because the human feelings and empathy cannot be replaced. And also another thing is privacy and consent. Monitoring raises issues of data privacy and dignity. So again, that is a ethical consideration. This ethical issue we will be dealing separately in a separate class. Another thing is, in a country like India, accessibility and cost both are debatable, isn't it? Now accessibility, again in Kerala, most of the houses we do have smartphones these days, I think if you see. So accessibility can be to certain extent, but cost again, when you go for sophisticated things like AR and VR and all, cost may become. So that is what I was telling, the CSR, corporate social responsibility, sponsorship may be utilized in cases which really need it. Another thing is, robots should not replace human compassion and presence, because the human touch and feelings, looking at the eyes of the patient, having a comforting touch to the patient, which cannot be provided by the robot, which can be given by. So I am telling you, actually, you cannot replace it. You can only supplement the caregiver, or provide some amount of caregiver burden, reduce the caregiver burden. Robots may be utilized. Next is mobile applications. So mobile applications are also used for helping the patients and families to track symptoms, medications, and even communicate directly with the care teams. Now these days, even actually many times even cameras being installed, and the children staying in US or UK may be monitoring what is happening in that. So many times they are the ones who is watching and alerting the neighbors, etc., on those type of things. So that is also, mobile application can also be utilized for this. Next is artificial intelligence in palliative care. So AI is playing an increasingly important role in palliative care. So many times it is being used for predictive analysis. It means they monitor a lot of data of the patient and give predictive analysis, like which treatment can do this, how much, what time they should start, and depending on the ECG or maybe all other results. No, when they analyze thousands or maybe lakhs of records, and then based on that experience they may predict it. So it is used for predictive analysis. So it can also be used to extract important information from unstructured clinical notes using natural language processing. So again, it can be utilized for, this can be utilized to help us to plan for the care. And also chatbots can provide basic support, answer questions, and reduce the workload for clinicians. So again, this can be utilized. They can ask the patient or observe and then transfer the data to the caregivers or the healthcare team. Then again, AI can assist but not replace care providers, freeing them to focus on human side of the care. So to certain amount we can utilize them, but we cannot. Artificial intelligence also, like any other machines, it can also assist but not replace human care or human touch. So coming to advantages of chatbots, maybe it will use immediate response can be given, available for 24 hours, and medical knowledge is accessible, is like it is instant access is provided. Maybe help us to use smart use of resources, and it is used actually for high patient satisfaction, because the questions are answered and things like that. And care cost also can be reduced, but not in our situations, in foreign countries and all where they are using this. It is being seen actually, it can be incorporated. But again, here also, if the patient can afford, if the family can afford, so those type, and if there is no caregivers to provide, like, or maybe there is nobody to relieve the caregiver, or even the home, then these type of things can be utilized in place. Because many times we do have shortage of staff, so there it can be utilized. So these chatbots are basically the programs that employ artificial intelligence and natural language processing to stimulate conversation with the patient. So chatbots can be utilized to continue conversation with the patient, so that the patient can answer, the chatbot can answer. So keep them engaged actually. So another thing is they are available 24 hours. So chatbots, they don't get tired, they don't need to sleep. So that is one advantage of them, because whenever the patient needs, may be available. They may be also used for appointment scheduling, data gathering, medication reminders, and may be also used for assessing the symptoms, illness monitoring, and also providing mental health support. May be also used for, and another thing, as I was telling you, they never get tired. So that is what is the plus point of chatbots. We human, we get tired, we feel fatigue. So there they can be utilized. So again, it can be used as an assistive device. And it can be, they are ready to ease the burden on clinicians, nurses, and to improve the quality of care given to the patients. Coming to the benefits, it empowers the individuals with mobility issues and to participate in virtual events and maintain social connections. So that is again, like we know actually, like Father was telling today, actually their older priests were given smartphones, and so same way, like those type of things also can be utilized to keep them in touch with to maintain the social connections. It can also be used to enable remote consultations and care for and can facilitate social interactions for palliative care clients. It can be used also to educate the children to attend classes and connected with, especially for in the pediatric palliative care, when they can be online classes. Those type of things also can be utilized. Now here again, we are using it actually. This is a live streaming. So many people from different institutions may be attending this. So this is also an a utilization of computers in education, isn't it? So this is, we are practically demonstrating how it is utilized for benefit of improving the knowledge. Next is telehealth in palliative care. Telehealth has become game changer, especially since the COVID-19 pandemic. Many times, especially in e-Sanjeevani, isn't it? Through e-Sanjeevani, consultation is being done, carried out very successfully. So, like actually under Ayushman Bharat, there are community health officers posted in various Ayushman Arogya Mandirs. They do use, the patients when they come, they do use actually this teleconsultation, e-Sanjeevani, for prescribing, especially antibiotics. They are in their standing order, they are not being allowed to give antibiotics to the patients. So they can use teleconsultation to prescribe antibiotics for their patients. So it is being successfully used. So this is also used for palliative care patients. So telehealth has emerged as a transformative tool in palliative care, offering new pathways to deliver timely, compassionate support to patients and families, particularly in those rural, underserved and homebound settings. So it can be utilized. I was telling you about one of the e-Sanjeevani is being practiced all over India successfully through Ayushman Arogya Mandirs. It supports ongoing symptom management, medication adjustment, and psychological counseling via computer or phone. Even psychological counseling, you have many times we do have like psychological counseling for these patients when they have been. You can refer, either the volunteers or the caregivers or the palliative care nurses can refer these type of patients, or the caregivers of the family caregivers can refer the patients for this type of counseling. So as I was telling you, actually, it can be utilized for remote symptom assessment and also care coordination. And it can be also used for advanced care planning. Again, advanced care planning, we do have a session tomorrow. We'll be discussing in more detail about that tomorrow. It is also used for home-based palliative care where these patients are, means caregivers can ask support from the palliative care team. It is also used for family and caregiver support, and it may be also used for emergency triaging. It means when a patient is having some acute problem, like advice can be given by maybe through a video conferencing, maybe through a video consultation, patient can be, emergency triaging can be done, and whether the advice can be given, whether it can be managed at home or whether the patient needs to be shifted to a hospital or to a hospice. So, what are the benefits of innovation? So, we can identify patients who need support earlier. Maybe I was telling you through analysis of the data, etc. Sometimes even before, maybe when is the palliative, when we need to shift the patient for palliative care. And also another thing is patient may gain more autonomy and independence over their care through digital tools and education. Innovations improve communication between patients, caregivers and providers, making care more cohesive and less fragmented. So again, here we are able to integrate the innovation, so we are able to provide a better care. Care becomes more proactive rather than reactive, focused on preventing the suffering rather than just treating it. So, but next we will see what are the challenges. So anything which has got benefits will also have challenges, especially in a country like India. So major concern is data privacy. When you are giving it, so there is a lot of data leakage. So data privacy may not be, sensitive personal health information should be dealt securely, otherwise the data privacy may be tampered. So another thing is digital literacy. All patients may not be comfortable with the technology, so they need to be taught or they need to be provided basic information how to manage this technology. And there are in India also, we have so many communities still lack internet infrastructure needed for telehealth, and many health systems still struggle with reimbursement models and regulation, like many times Wi-Fi connection may not be there, net connection may not be stable and those type of things. These barriers must be addressed to ensure innovation benefits to all the patients. So looking ahead, the future of palliative care will likely involve even greater integration of technology, because I was telling you, because of the staff shortage, because of the aging population, because of the type of disease suffering we do, because the cancer and those type of cases are being increasing day by day. So we need to have integrate the technology to ensure that proper care is given to the patient. We will see AI tools embedded directly into electronic health records, offering real-time clinical decision support. So maybe like in your time also, maybe we are able to, you all also, when you become clinicians, you may be able to contribute more to these innovations. So remote monitoring will become more sophisticated, enabling truly personalized care at go home. It means we may be able to provide advisors through a video conferencing or maybe a Zoom meeting and things like that. VR and AR may expand caregiver support and even grief counseling. It may be used for bereavement support. But as we innovate, we must also invest in research, training and policy to ensure these tools are effective, ethical and accessible. That is very important. the ethical aspect of this technology. So we need to ensure that we need to do research to ensure that, to see what is the benefit, how it is. Like before, we need to have evidence actually. So research has to be done to ensure that we are providing, this is being used ethically. So to conclude, innovation in palliative care isn't just about technology. It is about using tools to enhance compassion. So emerging technologies, artificial intelligence and telehealth offer powerful ways to improve the access, communication and also quality of life. Innovation should always support, not replace. I repeat, innovation should always support, not replace the human head, heart and the hand as the core of palliative care. So, core of palliative care is with your heart, with your head and with your hand. And so this new frontier is about building a future where care is not only more advanced but also more personal, more respectful and more responsible to individual, which is tailored to the individual needs of the patient. So basically, innovation in palliative care is not about automation or digitalization. It is about personalization in palliative care that makes all the difference. It means you have to provide care to the patient based on the need of the patient, based on the accessibility of the patient, based on the cost effectiveness, whether the patient can, affordability of the patient. And compassion of the heart of the compassion is the heart of the palliative care, and innovation is the hand that carries it forward. Okay, thank you. Any questions?
Thank you, ma'am.
Any questions? Okay, all are thinking actually lunch break time, isn't it? It's okay. Have a nice afternoon.
Thank you, ma'am, for such an inspiring talk. Now it's time for lunch break. We request everyone to kindly leave the auditorium and enjoy your lunch. Please make sure to return by 2 p.m. Thank you.
Reliable, eco-friendly electricity. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining the movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. Imagine a future powered by clean, renewable energy at solar. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining a movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. A solar revolution is ahead. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining a movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. A solar revolution is ahead. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining a movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. A solar revolution is ahead. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining a movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. A solar revolution is ahead. Imagine a future powered by clean, renewable energy at solar base. We're making that future a reality today. Our state-of-the-art solar power plants capture the sun's energy to deliver reliable, eco-friendly electricity for homes and businesses. You're joining a movement towards a greener planet. By choosing us, you're not just investing in sustainable energy. A solar revolution is ahead.